So we'll be ready to start in about a minute. Okay, we're almost ready to start. I'll just give you a few pointers on the microphones. You're very used to using them by now, I know. But just to say, they are all wired together, so please move to them than dragging them around and passing them around. Secondly, when you finish speaking, switch off. Formally start the meeting. If I just get the signal that we're right, we are now live and on camera and on sound. There's quite a long list of announcements that I want to start off with, including apologies for absence. First of all, we have apologies from our area director for the North. You don't know him yet because he's fairly recently been appointed, Levi Buckley, and Rachel Mitchelson's deputising for Levi today. Apologies also from Anne Workman, Kath McAvoy-Carr, Eileen Kaner, Claire Riley's unwell, so she's unable to attend, and Jane Hartley. And so let me come, because the announcements are tied into some of those individuals. First of all, to say that Anne Workman is one of our local authority partner members, is retiring and stepping down. So had she been here, this would have been her last meeting. Now, I'd just like to say a few words of tribute to Anne. She's really had a remarkable career. She's someone who's greatly valued, not just in the North East and North Cumbria, but nationally as well. And in a personal capacity, she was extraordinarily helpful to me when I was helping to set up the ICS before the ICB came into place. And I know since then, not just as a board member, but offline as well, she's been enormously valuable source of wisdom and advice to Sam and other members of the team. David Thompson is last meeting as well, and I think David has also been a huge benefit to us as a board, bringing the Health Watch perspective into play, and I think his questions, his measured comments, and his pointers to things that we should be focusing on. We're going to miss you greatly, David, so thank you very much for your service to the board. Similarly, Jane Hartley is stepping down, and Jane has also carried forward work in helping to set up the integrated care system to becoming an integrated care board member, and obviously part of our board for the last year. And Councillor Shane Moore, one of our partner members following the local elections, is has resigned, formally resigned from the board. So we have some vacancies to fill, and they'll all be following a due process, and hopefully we can have most of them in place by the time of our next meeting in July. There are 8 members of the public in attendance today, and also some of the team delivering primary care in the North East and North Cumbria are going to be joining in the presentation, which is one of our main agenda items today. So those are all the preliminary announcements. Just to ask then, are there any declarations of interest that are not already in your record of declarations? Ken?
Yes, can I declare one under 9.2.1 and the Appendix 1 specifically, which is hopefully going to allocate resources to NHS organisations in the North East North Cumbria, one of which is mine.
Thank you very much, Ken. We note that declaration of interest. Minutes of the meeting held on the 28th of March 2023. Are there any points of accuracy, first of all? No. Are there any matters arising not otherwise covered on the agenda? Okay, thank you. The action log. Deb, are there any points that we need to pick up on that?
They're all covered on the agenda.
Yeah, they're all covered on the agenda, and unless you've got any points from there that you want to raise, we'll come to those matters as they arise on the agenda. Okay, I turn now to Sam Allen, our Chief Executive, for her Chief Executive's report.
Thank you, Chair, and good morning, everybody. I'll take my report as read this morning, but there are 2 particular items that I just want to cover in a little bit of detail. The first one being the financial position and some of the longer term considerations. Now, we will, of course, pick this up under a later agenda item, particularly looking at finance. However, given the planning period with which we have just gone through for the year 23-24, and where we have ended up in terms of the North East, North Cumbria, I felt it important, and certainly my report covers in some detail, some of the issues that have been fairly long-standing here in the North East and North Cumbria. And my report refers to what I've termed the quadruple whammy. So a region that's dealing with greater health and care need, and that reflected in the long-standing health inequalities in our population in the region. These being made worse by the pandemic. Our region was certainly hit harder during COVID. We have higher rates of long COVID in our region. The rurality that our region serves and the expense of providing services to large rural areas, and also what we're seeing, which is reduced funding. So this year for us, that's a reduction in funding of 19 million, and in the previous 2 years, a reduction of 100 million. And next year, we'll see a further reduction in our funding available to the region of 60 million. And these being a result of the national funding formula that was set in place pre-COVID. So as you can imagine, this coupled with the extra inflationary cost pressures we've seen across the nation this year, and the impact for us being a region with certainly a high number of private finance initiative capital schemes, which this year alone we've seen the costs go up by some 19 million, makes for a very challenging period when it comes to not just our financial planning this year, but our medium to longer term planning. So what does that mean for us? It means that we have posted a deficit plan for the first time this year, a deficit plan just under £50 million. And we've commenced work on a medium to longer term financial recovery plan. Now, we have got some opportunities there, I think, particularly with public sector reform, working particularly closely with our local government colleagues, with certainly the opportunities that the devolution deals afford to us, as well as our own goal and our own strategy of integrating services, particularly our community models of services. But I don't think we should underestimate the challenges of which we're facing, and indeed our providers are facing, In setting our plan this year, we felt it was incredibly important, whilst needing to have stretching efficiency goals and plans. We felt that keeping these under 6% efficiency plans was going to be realistic, and in fact that's what we've done. So our providers, our NHS providers, have got efficiency plans of between about 4 and 5.7%, none exceeding 6%. So I suppose the picture I'm painting there is one of a particularly challenging picture, something that we need to get a grip on. And we're very focused at the moment, particularly in our medium to longer term financial recovery planning. It's not a position I think we'll be able to turn around over the next 12 months. We're certainly looking at a period of the next 3 to 5 years. And we'll do that through transformation of services, greater collaboration, and as I've said already, taking the opportunities of public sector reform. So whilst there is opportunities there, it is a particularly challenging picture. And I think if we look at taking decisions of equity, particularly given the fact we have life expectancy going backwards now, not increasing, one where we have to also, I think, be realistic about some of the national funding infrastructure and the challenges that brings, particularly to our region. The second area, Chair, I just want to highlight is NHS dentistry. So the board will be aware that we took responsibility for the commissioning of NHS dentistry services on just recently from NHS England. That's been delegated to us, and you'll see in my paper a piece of work which I think is absolutely essential. We're looking to bring this back to the board in the autumn, whereby we take a very thorough look at oral health of our population and also dentistry, NHS dentistry services across the North East, North Cumbria. I think this is, again, a challenge that many of our fellow integrated care boards across the country are facing, in terms of not only the impact of COVID, but also a situation where we have reducing number of NHS dentistry services available to the population. And we know that this is perhaps one of the public's biggest area of concern, and again has a particular impact in the overall health and well-being of our population. So now that we have responsibility for the commissioning of this as an integrated care board, it's really important we understand both the magnitude of the challenges that we're facing, so that we can put in place, again, what I think will be a medium to long-term recovery plan. Having said that, some very early conversations with NHS dentists across our system, we think there could be some early steps we could take. One of them, for example, running a campaign supporting particularly school-aged children around oral health and the opportunities available there. But this is nonetheless probably quite a significant risk we're facing, both in the early availability of dentistry and ensuring that we can make that available for the population. So, Chair, I'll take the rest of my report as read and happy to take any questions.
Okay, so questions and comments on the Chief Executive's report. And Hannah, you previously declared your family interest in dentistry, so we note that if there are any questions in that area. David.
Thank you.
Microphone, please.
Thank you. 2 questions, if I may, Sam. First of all, you mentioned the success measures in your report, and amongst the priorities, the high profile towards prevention, reducing inequalities and so on. And yet when you mention the running costs and the challenges there, and the challenges you've just mentioned there, I was wondering how might this financial picture impinge on the ICB's ability to really make an impact on inequalities and prevention. So I know the will is there, but will the means be there with all of these financial cutbacks, especially since in the Hewitt report it suggested increasing expenditure on prevention. So I'm just wondering, is it possible to really develop these themes and make a difference with the financial constraints?
Thank you, Dave, for that question. I think it would be fair to say it is going to be a particularly challenging period, and not just this year, but in terms of the years ahead. The Hewitt report was quite clear that really wanted to see an increase in the funding that we spend on prevention over future years. We have ring-fenced our funding for prevention, so we're spending £13.6 million on a prevention fund that we've agreed the priorities, working closely with our Directors of Public Health across the system, and we've committed to ring-fencing that. But nonetheless, in line with you, we would certainly want to see that increasing. And given the landscape and our population health needs, we certainly should be in future looking to actively redirect more of our funding to prevention. I think the challenge with the running costs is a slightly different one, which is the Integrated Care Board at a time of significant transformation and prioritisation. We are going to going through a process of reducing our running costs by 30%. We've designed a programme to try and minimise the impact on staff, but nonetheless there are risks there, David, and I think we've been quite clear about the risks that we're facing there.
And the second one, if I may.
Just before you come on to the next one, David, I just wanted to add briefly to Sam's comments. I think if we look at the long-standing pattern of poor health and preventable disease in this part of the country, I think the three things that strike me, if we're going to be able to move forward on it, one is the commitment, which is undoubtedly very widespread, to act on it. The second is, to a certain extent, money. But the third area, which has never been satisfactorily resolved, is how to do it. What is the process? What is the model of change? Have we got the creativity and methods to be able to do that? And I think that's where our improvement programme comes in. But it's very striking when I showed the examples of data earlier on bowel cancer, hypertension and so on, and exploring it a little bit further, it's where this idea of redesigning the system, the pathways of care, comes in. And much less work over the years has been done on that way of achieving change. I think there is a big opportunity, but the barrier, in my view, will principally be getting the right expertise round the table to produce a new way of doing things. We've got some fantastic universities, some fantastic clinicians, and I know, for example, on the bowel cancer, we're probably best placed compared to anywhere in the country to move forward on early diagnosis of bowel cancer, knowing all the work that's going on. So I think let's make sure we create the space and time and get the experts involved in that. Your second question.
It would be remiss of me not to mention dentistry again, but I think the approach you've taken is very pragmatic in terms of bringing people together for a long-term strategy, but in the meantime, seeing what you can do to remedy the worst effects. There's a lady in Stockton, I've got all the reports here from the Health Watch Network, and dentistry is still top of the list. And a lady in Stockton made 65 contacts to dentists for emergency treatment. She got one response, and that said, yes, we can do it, as long as you go private. So it is real. But in terms of your report, you mentioned the benefits of oral health. I think it's more than just the medical ones. I think it's the social one as well, because halitosis, unsightly teeth, can affect social life and also could impinge on work. Because if someone has toothache or whatever, it's hardly conducive to working effectively, absence from work. So there's an economic as well as a social benefit from oral health, which wasn't mentioned in the report. And finally, it says that you want to engage with the citizens' views. Just to let you know that the Health Watch Network in June is going to do some engagement work with the wider public on why they are not attending for regular dental treatment. You know, what are the causes why? And I'm sure we'll be able to work with you to find out what the public are saying. And that, I think that work begins in June. Okay, thank you.
Thank you, David.
Other comments and questions? Hannah.
Thank you. My first question was just around the timeline for this. It's just it seems maybe a little bit tight. I understand obviously there's a need to do things quickly because we need to move forward, but to do a review that is detailed enough to be able to give the recommendations and cover the areas that you've outlined, I just wonder whether having something by October is a little bit too ambitious.
I think it's a fair challenge, and it was certainly something we discussed as well. I think given the urgency of the situation, we felt even if it's reporting back preliminary findings by October, Hannah, but it may be that we need another 3 months in order to do a really comprehensive piece of work, I think particularly with the summer period, but getting an understanding this year as to what some of those early actions are, we felt was just absolutely essential given the urgency of this situation and the sort of the pressing need. I think the other thing we were keen to do is obviously work with all of the overview and scrutiny committees at places, Health Watch. There will be a number of people looking at this and how we can coordinate and pull together the findings of the work they're doing as well. So it may be that we bring preliminary findings back in October and something more comprehensive early in the new year.
Thank you. I did just have one other question as well, just about the scope. I wondered whether the role of employers might be considered in this, in that many have either already exists or there is the opportunity for employers to be involved in supporting oral health, potentially as a benefit, an employment benefit, so vouchers or schemes whereby you can have entitlement to that, or if they're not currently doing it, it might be something that could be looked at.
I think that's an excellent point. It certainly builds on David's point around the economic benefits and the links as well. We could certainly include that within the scope. Thank you.
Just on two quick points, and then I think, Dave, you want to come in just to... One is, I can't help but mention fluoridation. It's been an incredibly frustrating journey for the whole country, or particularly this part of the country, and I think it's something that we really have to get back into and make it happen. The second thing is when you talk to people around the country involved in some of the thinking about how the problem of access to dental care can be solved, there's a lot of discussion, I think, about the role of the dentist and what sort of work they do. And most of that thinking is turning on the idea of having a staff member who does the more routine side of dentistry, leaving the dentist to do the more specialist work. Now, that obviously has been moving a little bit in different parts of the country and different parts of the world, but it does take time to train a workforce of that kind. But it's definitely, I think, a direction that dental practice will be going in the future, and there's probably the only way to create a sustainable solution to the problem. Dave Gallagher.
Yeah, thank you, Chair. And Hannah, I would recognise certainly the timescales are a challenge. The good news is we're not at a standing start with this, so there's some work in terms of the workforce that the Chair's just alluded to. Equally, though, and probably most importantly, there's some really good work that the Directors of Public Health Link to Dental have done already, so they've started to get a picture. This piece of work would really bring everything together into one place so we can then determine what the strategy is going forward. So lots to be done, but it's not a standing start.
Graham Evans.
Thank you, Chairman. My point's related to section 3.6 of the Chief Exec report and the Analytics Academy. Just to give the board some further update, we've actually got a really good uptake now across the health and care system within the region. We had originally 50 student places that would be offered against 2 cohorts. We've actually got 10 spaces reserved for NHS England colleagues, and we have 5 or 6 vacancies that remain. However, we've got sufficient cohort capacity now to actually run the programme, commencing the middle of June. It will run through the summer period and conclude around about November time. But just picking up the Chairman's point earlier about the importance of data, this is yet another building block in creating the capacity and capability within our system to create analysts. Thank you. Thank you, Chairman.
Thank you. Are there any other comments? Okay, well, with thanks to Sam, we'll move on from that agenda item. Now, the next item is a strategic item. As you know, on previous agendas, we've had one or more deeper dives into an area of strategy, and this time it's primary care. It won't be the first time that we review this subject, but I thought as a starting point we would start to talk about how primary care works in the North East and North Cumbria, some of the challenges, some of the strong features as well. And this item is going to be presented by Dave Gallagher, our Executive Area Director, and Dr. Joseph Chandy, sitting at the end, the Director of Transformation Primary Care. There are one or two other speakers who will be introduced by Dave whenever it comes to that point in the presentation. And we have three practicing GPs on the panel, Syra, Mike, and of course our medical director. And I dabbled in it a little bit in the past, so I'm sure we'll get a bit of professional opinion on the practical realities as well. So I'll pass over to you, Dave. We've allowed a good amount of time for this discussion, and the presentation will not take up the whole time, so please feel free to formulate your questions and comments or prior thoughts on this subject, and we'll have the chance for a fairly full discussion before we have to move on to the next agenda item.
Okay, thank you, Chair, and thanks for the introduction. I think...
Dave, you might need to go a little bit softly spoken, a bit closer to the microphone.
So I don't know if you promoted or demoted Joseph. Joseph's not actually a doctor. I don't know how you feel about that, Joseph.
I dabble a bit.
He dabbles a bit. But I've also brought other colleagues along with me because this is quite a big topic to get into. So behind me, and we'll do a bit of moving backwards and forwards to the table, I've got Helena Gregory, who's from our Meds Optimisation team, Vanessa Connor, who's from North Cumbria, and Edward Kanunga, who's involved in health inequalities, and particularly with the deep end practice as we get into it. So quite a big topic, quite a number of slides to go through, but this is just to scratch the surface and then get into some of the details as we go forward. Want to start though just getting our sights in the right place for this, and this is something I'm really guilty of. I talk about primary care. There is primary care, and as colleagues will be aware, and as the slide indicates, there are actually 4 professions that are involved in primary care. We've now got responsibility as an ICB for commissioning all 4 strands of those. All of them are quite heavily regulated by NHS England, so there's some constraints we need to work within. But the important piece for today is we're focusing largely on general practice as part of this, and we'll pick up other conversations about the rest of primary care as we move on. Other than there's a big part that general practice has in terms of prescribing, so we are going to talk a little bit about some of the prescribing challenges and opportunities that we've got as we move forward. Just to give a picture for the makeup of general practice within the North East North Cumbria, there are probably 3 types of organisations, if you like. The smallest unit in general practice is the practices themselves. They are the organisations that we contract with as part of that delegated responsibility from NHS England. They're increasingly working more closely together in primary care networks that cover various parts of the geography. As you can see, the 347 practices that we have are organised into 67 primary care networks. The primary care networks, or PCNs, are not formal organisations, therefore we can't contract with those. We can contract, though, with the GP federations that we have that cover a lot of the geography, but not all of it. As you can see, mostly to the northeast part of the patch. There isn't a federation at the moment in North Cumbria. So we do contract with the federations for things like out-of-hours cover. The primary care networks are quite interesting in that if you look at the numbers, there's a couple of oddities there. The only one that's completely coterminous with the local authority area is in Darlington, and that's something to do with size and scale, but it has advantages. The other slight oddity, you might wonder why there's 2.5 practices in Redcar and Cleveland, so 2.5 networks in Redcar and Cleveland, and 3.5 in Middlesbrough. That's simply because of the geography. They actually share some that straddle across the 2. Like hospitals, like care homes, the Care Quality Commission provides a view on the quality provided by general practices. And as you can see, actually in the North East and North Cumbria, the practices do really well. The majority of practices, 304 of them, are rated as good. We only have 4 at the moment that require improvement and 1 that is deemed to be inadequate. And this is at a point in time, clearly, and that does change here and there, but actually the number of good and outstanding should give some assurance that actually practices are doing really well in terms of meeting the CQC requirements. Notwithstanding, though, some of the challenges that they're facing at the moment that we're going to talk about in a little while, which might mean some changes to that as we move forward. That's probably a little small to look at, but in terms of the waiting times to get appointments with practices, which is one of the key things that I know tests local people at the moment, as of March of this year, actually practices in North East and North Cumbria fare reasonably well. Comparison there with the England average, so in terms of the number of appointments per 1,000 population, for North East North Cumbria, 559, which is higher than the average for England at 509. Despite an emerging from COVID, 75% of those consultations are now seen face-to-face, which again compares favourably to the England average of 70%. We probably do slightly less well in terms of same or next day appointments, with 41% compared to 43%, and 13% seen within 14 days. We must remember, though, when we think about this, that actually not everybody wants to or needs to be seen immediately. There are reasons for being seen at a later date. Things like if you want to have medicals or other things where you need certification from general practice. We talk about general practice and we talk about GPs, and there's again possibly a bit of a perception amongst the public that I must go and see my GP. When we look at the workforce that we've got in North East and North Cumbria, yes, we have almost 2,000 GPs, but we also have 1,200 nurses and an increasing number of other roles, which Joseph will talk about later on this morning, that provide clinical services where you don't need to see a GP because they've got the right skills, experience and qualifications to actually work on behalf of the GPs. Keeping GP skills and expertise to focus on the areas where you do actually need to see a doctor. I'm going to hand over at this point to Joseph, who's going to talk now about the elements of the funding for general practice to provide a little bit more context for everybody.
Thank you, Dave. Thank you, Chair. Thank you. Yes, this slide just describes funding for general practice, and the majority of that funding is made up from the core element, which is based on a formula of the number of patients registered and a mix of their age, the deprivation of the population, etc., to then try and give a fair funding to each practice. And then, as you know, general practice does a lot more on top of just seeing their patients for their day-to-day needs. So it offers a lot of prevention services, which you talked about earlier, Chair, which is childhood immunisations, cervical screening, immunisations, shingles, flu. And so a lot of that funding is made additionally through enhanced funding. System development funding gives the ICB the opportunity to see where we can be innovative with general practice. So that is funding one-off, non-recurrent funding. It gives us the opportunity to talk to general practice about what initiatives we can test and pilot to support the transformation of general practice. And finally, primary care networks is the collective that Dave talked about earlier of practices coming together for their neighbourhoods. And that initiative has now been going 5 years and is funded to support general practice in carrying this out through the primary care network DES. In addition to that, there are, by NHS England, several initiatives that are taking place so that we can actually improve general practice and make it a modern general practice. And some of those is around supporting general practice with other routes other than just into the GP by expanding community pharmacy. And later on, we have a slide that expands on that. Primary care transformation, how can we modernise general practice? And there's funding for that. A lot of this is enabled by new technology. So in a lot of sectors out of health, we now are supported through digital apps and the public being empowered to do more than going through their front door of that service. And we're trying to emulate that in general practice as well. And so there are funding initiatives that we have to make the most of in the North East and North Cumbria so that we can improve our general practice for tomorrow. Next slide. And with that funding is coming strict ambition from NHS England in terms of increasing the number of appointments available for our patients, with a promise to have more GPs, because despite what we provide today, which Dave has shown demonstrates quite favourably, we still need more GPs to provide the service and make it sustainable. 26,000 additional roles in general practice, and we're already proving both on a national level and in North East and North Cumbria that we are on target to meet the additional roles that support GPs and offer extra routes for patients to be seen. And it's been very topical this year, and we've heard a lot from our population and the public about trying to race to get through to the GP surgery at 8 o'clock in the morning, to be held for a long time on the phone, be number 30 odd in the queue, and then find that they can't get an appointment that day. And the government wants an end to that. And a lot of the initiatives we're talking about in this presentation are around how we're going to approach that.
Just before you move on, Joseph, that national targets or for the North East and North Cumbria, those numbers?
These are national targets, Chair. And patients need to know how their care will be managed. So quite often they complain that once they get through, there's no appointment and they're left hanging and they have to try again the next day. And the government wants an end to that by at least letting the patient know if they're not having an appointment that day, what the course of action will be. So in this national context that we're talking about, they have outlined 4 steps to recovery of general practice and access. And first and foremost, they put the patients at the centre of that by empowering patients. And that's so that patients have the opportunity to access their general practice, not just by ringing up and asking for an appointment, but there are other routes to be able to talk about their condition, whether it's digital via an app, whether it's by video. All this is to be developed in this coming year. And there's a belief that general practice has to change, that the general practice of today isn't fit for purpose. So they're setting out an initiative of modern general practice and a programme to support practices to be able to take the steps around reflection, improvement, and developing a new general practice for tomorrow through this initiative. This can't be done without building capacity. So there is funding for a number of workforce initiatives, especially around recruitment and retention of GPs. And when we listen to our GPs, and a number around the table will confirm this, a lot of the times they can't see their patients because of the bureaucracy that surrounds their work. So there will be a drive this year to work with primary and secondary care to look at how we can reduce the paper chasing and just get on and see patients. But we must highlight that it's not all doom and gloom in general practice, and general practice is well known as an excellent delivery model for patient care, and they have overcome a number of challenges over the few years and successfully delivered, especially on the COVID vaccination programme, which was an enormous feat and showed how nimble general practice can be in terms of delivering and supporting patient care. Coming out of COVID and delivering more GP appointments than ever. Our successful flu vaccination, which as a chair you will endorse, is essential in terms of saving lives and providing a healthy population. Screening, and if we focus further and further on screening, we can prevent downstream a lot of illness or lost lives. The development of primary care networks and the additional roles, and digital opportunities, as we've discussed, are now being embraced. But when we talk to general practice, they still say that from their point of view, there are a lot of areas to overcome, and particularly around the requirement for more workforce, the stress from regulation, supporting us to develop new roles in general practice, but the amount of time and supervision that requires, pension challenges, which of course have been in the news, fear of litigation, just to name a few. I want to talk about this exciting development. So in the last 5 years, there's been significant investment into general practice to develop additional roles so that, for instance, your GP is not necessarily the right person to see every time. We can keep GPs for the specialist ongoing care. So we now have, for instance, physiotherapists that we would never have had before in general practice. We do know that a number of contacts into general practice are from sports injuries over the weekend, playing rugby, or tripping over something. And these are things that can be seen straight away without waiting for a GP appointment, with the number of physiotherapists now working from general practice. Social prescriber link workers who can now look at some of the non-medical problems and navigate and support patients' care by linking them with opportunities in the community, in the voluntary sector. Paramedics are now coming out of their traditional setting and are proven to be very good at first contact urgent care. And so that's just a number of the roles that you can see that are developing, so we're not so reliant on our GPs. But general practice has to be strengthened, and we have to underpin that with the right tools. So workforce, developing the digital technology so that we can keep to pace and support our patients. Premises. So we do know that a lot of our GP practices are now undersized with this expanding workforce, or have got complex lease negotiations to extend their life of their premises. And importantly, we still have a lot of work to go in terms of not only recruiting GPs, but also persuading GPs towards the end of their career that there are the flexibilities for them to stay, rather than losing them when they're at their prime. So when we talk to general practice, there are three main bodies of representatives that have developed, which is the GPs through their local trade union, the local medical committees, GPs that have come together around their neighbourhoods and populations in primary care networks, and GP practices who've developed larger groupings called federations that support them with a lot of the bureaucracy and back office functions. And actually, we need to have the discussion together, and there needs to be a common voice. So the ICB has been very supportive in supporting general practice and developing that voice, and that is the Primary Care Collaborative. We believe general practice in its various forms, collaborating as one voice, will then allow them to be able to shape, inform and influence our agenda together for primary care transformation. And importantly, we all recognise with the opportunity now that we commission pharmacy, optometry and dentistry, that there's a significant opportunity for us, primary care and ICB, to be able to join together. These conversations have never had this landscape to do that, and actually work together as professionals on what's best for the patient. In general practice, we see so many dental problems. What is it do we need to do in terms of a dental and general practice conversation to provide a better pathway for patient? And that was illustrated earlier in the conversation at the beginning of the board meeting. And pharmacy and general practice, sometimes they're co-located next to each other, but never the conversation happens about which door is the right door for patients. And I believe this collaborative will give us that opportunity to further improve patient care. I think it's important to refer to Professor Dr. Claire Fuller, who's actually done a report known as the Stocktake on what are the opportunities for our local populations within this integrated agenda. And now that we have the opportunity as an ICB to work together across all providers, how can we do that in a way that benefits the patients in their neighbourhood? And her blueprint sets out, which we've tried to pictorially represent here, the opportunity with the patient at the centre of it, of how we can, as providers, whether it's general practice, community nursing, our adult social care, voluntary sector, mental health, to name but a few, come together, because when the patient is vulnerable, a number of them services are serving our patient. But do we all know what the other is doing? Do we sometimes go through that front door, that patient too many times. And we do believe there is an opportunity to improve the quality of care of that pathway for those patients with this neighbourhood approach. And as Sam referred to in a Chief Executive report, that will bring efficiencies as well that we can reinvest for the benefit of patients. And this quite simply describes that the integrated approach described by Care Fuller will happen at a very local level, currently known as primary care networks, but will develop into integrated neighbourhood teams, and at our place that we have within the ICB as well as at the ICB. And the opportunity is at all levels. We can talk to all system partners. That includes our academic and innovation approaches, academia, university, public health, so that we can actually set out a blueprint for the future. So now I'd like to hand over to my colleague Helena to talk wider about those pharmacy opportunities we talked about.
Thank you very much. So we have 650 community pharmacies across the North East and North Cumbria. They're regulated by the General Pharmaceutical Council. The ICB and NHS England are currently handing over the commissioning and contracting, and supported by their local pharmaceutical committees across the area. There are big challenges and very big opportunities for this sector, which is in the heart of our communities, and they do have a huge potential to deliver, but there are risks associated with that, and they will need to be loved and cherished to help them get there. The same as every other sector at the moment, the workload and workforce pressures are tough, and it is really tough for them out there in a similar way to you've heard my colleague talk about general practice. But you will have heard again about the pharmacy recovery plan as part of primary care, and the pharmacy aspects of that are huge. What you may not realise is that was born in the North East and North Cumbria. The Chief Pharmaceutical Officer, David Webb, has on several occasions said that he was inspired by our Think Pharmacy First and urinary tract infection schemes. But he thinks that we can go further, that more conditions can be covered. We can develop community pharmacists to become independent prescribers and add additional services such as contraception. And we have some fantastic examples already. Collaborations between public health and community pharmacies. One small pharmacy in one small town delivered 350 blood pressure checks in a month and continues to do so. Referral pathways. Hundreds of patients have been directed from general practice to community pharmacies for urinary tract infections, and that has freed up a huge amount of their time. And COVID vaccinations, again, community pharmacy played a huge part in that, outreach into communities, buses straight into the heart of our vulnerable communities. They can and they will deliver, but we do have to recognise and develop the workforce. So, for example, with independent prescribing, where we have the large numbers of new roles coming into general practice, equally, we need to develop community pharmacy. So we will need to think about how we will have the infrastructure to develop those prescribers. That is something that the Integrated Care Board will need to consider. And also integration, as Joseph mentioned, as a primary care partner. So investing in our community pharmacy leads within our primary care networks, and how they work with general practices and the wider community teams. That's already underway through a community pharmacy leads programme, and there will be a series of events that will be held in June where those teams can get together and start to work around some of the priorities that we've mentioned, contraception, independent prescribing, infections, hypertension being just some of them. So we really look forward to the joint working and the support for those teams. Right, thank you. So on to prescribing in general practice. So we've got some data available for us, and we prescribe and spend more on medicines than other parts of the country. There are a number of reasons for this. So our demographics, an AstroPU that you see is a type of weighted patient, and the determinants of health that have been talked about right at the beginning by Samantha Allen do have an impact on our prescribing. So we might expect our spend on cardiovascular disease, on diabetes, those traditional preventative areas to be higher, but equally this has an impact on mental health prescribing, including antidepressants, pain, antimicrobials, and of course some of this has impact on individuals as well. Our cost growth is lower. You may look at this and actually think, well, 6.4% is still very high, and our teams are very much impacted by supply chain issues that you might have seen. This not only has the impact on cost growth, but also takes time away from procurement teams and prescribers to be able to deal with and to source alternatives. However, we are working hard to keep this under control. There are challenges around distributed prescribers across our general practices and other services. Central direction that may come without funding, such as NICE guidelines and recommendations. Interface issues where there may be unintended consequences of a decision made by one organisation or sector that affects another. Workforce, as we've talked about, and how we calculate the cost versus the outcome or benefit that we might see, which might sit in a separate budget. We're very good at starting prescribing and starting prescriptions and medications, but the systems and the cultures that we've built don't support our clinicians in that patient's expectations, in the review and in the stopping when it's warranted of that prescribing. And this can affect the quality of care for that individual. Are they getting the best thing for their condition? The safety for them, where there might be unintended harms from the prescribing, and of course the cost to the finance and to the environment through the waste that this generates. So there are questions, of course, we'll think about what can be moved upstream, and our personalised care teams, as was mentioned by Joseph in his presentation, pharmacy professionals do form a huge part of that. So they can review people's medicines for themselves, they can influence and work as part of the multidisciplinary team alongside other prescribers, using tools such as shared decision making and supported self-management as part of that multidisciplinary team, providing professional medicine support. And again, some of this may be moved upstream. So by working with the social prescribing link workers, the health and wellbeing coaches, the first contact practitioners, they can move some of this upstream where it belongs rather than feeling they have to medicalise. But this needs support at every level. So from supporting those primary care networks, they will need the guidelines, they will need the formulary, they will need the tools at their disposal on hand when they see the patient to help them to make the best choice around their medicines. And that involves our team supporting behind that. Again, the workforce development, the training, the guidelines, the formulary, the shared care to be in place and feeding through and working outside of our traditional spheres into the multidisciplinary working within our clinical networks. So we will be working in coming months to develop that support at every level. So this just some of the things that we've been through, having conversations around some of the difficulties that our teams are facing on the ground. Private providers, shared care are issues that we do have to work with every day that often provide very grey areas and there is no black and white easy answer. Again, having the conversations further up, such as adoption of the National Shared Care Guidelines, which is something that we're working through to do at the moment, and enabling and supporting our teams further down to work through some of those queries across the interface, supported by the teams working in our primary care networks. So we're aiming to do once where we can, such as the formulary for the medicines that we prescribe, and that work is continuing apace, which we expect to have complete within the next couple of months. The same for the governance systems. We're bringing together several area prescribing committees into one via the Medicines Committee and its subcommittees. And we'll be working to take forward some of the digital innovations, such as electronic prescribing outside of hospitals into community pharmacies, which you may be surprised at the moment to hear still happens on paper. And again, as we talked about, thinking differently about how we can look at some of the outcomes that we've got as part of the wider improvement work.
Thank you, Vanessa, for describing the huge amount of work going on in prescribing. If I may now introduce Vanessa, our community colleague from North Cumbria, describe how integrated neighbourhood teams are actually happening in action and the benefits for our population, as an example.
Thank you, Joseph. So I'm Vanessa Connor. I'm currently Associate Director of Operations for Community in North Cumbria. Back in 2016-17, I was appointed in a system role to lead the development of our integrated care communities. So at North Cumbria at the time, it was a bit of a burning platform, significant issues across the system, challenges in our local authority, as well as in our health services and our primary care. We were pretty much a fragmented system, and there was a recognition that we needed to do something differently and we needed to work together. So this predates, obviously Fuller, predates PCNs, and what we did was divided North Cumbria into 8 integrated care communities, or ICCs as they're known. They were based around GP practice populations. Some areas it was pretty much forcing GP practices to talk to each other because they weren't at the time. But what we did was we wrapped around these practice populations. So we went through a huge HR process with our community health services. And we went from having a system where we'd have very different offers from one patch to another until we had a consistent offer. We also pulled together our admin functions and developed what we call coordination hubs. So we went through what was a scattergun approach of contacting our community services to we've got one number for the whole of North Cumbria. So you can contact your ICC really easily. So if you're an acute provider, if you're on a ward, you know how to get hold of your district nurse, your therapist, etc. It's one number. And we also worked on some enabling factors. So, for example, our IT systems. So we went from having multiple IT systems to having one. So our community services, our GP practice are all on EMIS. So they all talk to each other, and we have got interoperability with lots of our other systems. And we also pulled together local leadership teams. So each integrated care community had a local leadership team, which included a GP. It included a community health manager, but then we also had social care, we had public health, and we moved on to have third sector as part of that leadership team as well. I think if we move on. So one of the reasons we wanted to do this was because of Bob and Sue. So, you know, I talked before about some of the challenges which you'll all be familiar with, finance, etc. But actually, it was about patients. So Sue was one of our patient participation colleagues who still works with us today. And this was Sue's experience of supporting her husband, Bob. So Bob had a number of comorbidities. Sue is a very intelligent, very articulate lady, but she really struggled to navigate our services. And this is the map that she produced of how she navigated our services. And as you can see, it's shocking, isn't it? So the amount of times that she went from one to another and back and forth, and we had to do something differently. So we had to work together to try and make navigating our health and care services better for patients. And at the time, I remember one of the patient stories that we'd heard that really resonated and that I remember very vividly was around one patient who in one single day had 17 different professionals come through her door, which is absolutely shocking. Okay. So part of the work we did with our integrated care communities, and this is trying to help the situation in the previous slide, was actually just getting people into a room together and talking to each other. So this is a picture from one of our ICCs. I think this is Eden. And this is one of our weekly MDTs. And our weekly MDTs is something that it's deeply embedded. They are just the way that we work in North Cumbria now. So at the MDTs, the professionals will look at complex patients and what we can do collaboratively. So on a weekly MDT, you'll have primary care, you have GPs, you've got sometimes you've got ambulance services, social care, third sector, district nurses, we've got therapists there. So it's actually looking at our patients and what we can do collaboratively and hopefully stopping the 17 people walking through somebody's door in the morning. We also have a daily huddle. So the daily huddles are really fast-paced, sort of 10-15 minutes in the morning, where you're looking at what patients you've got that day, and so you're looking at what your caseload is, what resources you've got, which patients you've got in hospital. You'd be looking at your end-of-life patients, etc., and actually collaboratively, what do we need to do to support our patients today? And one of the things you might notice about that picture is the number of laptops. So I did talk about EMIS and how we managed to use EMIS across our community health services and our GP practices, but actually we've still got a number of IT systems. So we still need to have lots of laptops open for our ICS, our social care platform, ambulance services, etc. So we're not quite there yet in terms of that full integration, but certainly much further along than we were.
Yes, thank you, Vanessa. The positive in that slide was all the professionals coming together. The negative in that slide was those 6 laptops, all with 6 different computer systems for the same patient, and none of the systems were talking to each other then. Thank you very much for showing us the art of the possible, Vanessa, with neighbourhood teams. And if I may introduce my colleague director from the ICB, Edward, who's going to talk to us about our challenges in general practice in terms of health inequalities and deprivation. Thank you, Edward.
Thanks, Joseph. So I'm going to talk about the DeepEnd network, which is a community of practice for GPs serving in some of our most deprived areas. The DeepEnd network is an idea that started initially in Scotland, looking at GP practices working with the most deprived communities and enable them to pull together practices that had similar challenges and for them to work together to identify solutions and also to look at new ways of supporting those patients. It's predominantly informed by the Inverse Care Law. So this was first described in the 1970s by Tudor Hart, who was a GP working in Wales, who observed that in the most deprived areas, you tend to find low levels of resourcing in terms of general practice. You tend to find the communities there are underserved by the services, and that results in poor access to services, poor experience, and ultimately poor outcomes. And that will then widen health inequalities. So in our region, we have a DeepEnd network, which is made up of 34 GP practices. The way we identified those practices was to look at the 15% most deprived communities across the region, and then started to look at where do we have GPs that are serving a high proportion of people from the 15% most deprived areas. So the 34 GP practices make up 7% of the population, so they look collectively after about 220,000 population. They've come together as a network, not exclusively, but to really utilize that community of practice approach to understand the problems, to share examples of good practice, and ultimately to create a coalition that can provide clinical leadership, but also advocacy for those practices. In terms of the priorities that they have been working on, the first one is around co-production and looking at how do we identify similar challenges and look at how best those challenges can be met, not exclusively within primary care, but also working alongside other partners. Also been able to share ideas of good practice. So we have looked at a whole range of new models of delivery of care and enabled us to work with our academic colleagues to evaluate those and then spread out the learning across the rest of primary care. Also been looking at workforce. How do we pull together the training opportunities? How do we identify, not only for those practices, but how do we build in an understanding of health inequalities across training, be it undergraduate, postgraduate, and recently managed to support a GP who was on a health inequalities fellowship. We've also been looking on the advocacy. So how do we bring those voices together? How do we utilize the data to understand the health resource utilization from these communities? And how do we benchmark against the rest of the population? I'm sure the board will be familiar with the national program called Core 20+5. This predates the Core 20, but actually has been very helpful in helping us understand some of the challenges in our most deprived areas and start looking at some of the solutions. Recently, through working with colleagues, academic colleagues, we've been able to publish at least 3 papers that are looking at sharing our examples and placing ourselves on the broader DPEN network that has now emerged nationally. In November last year, we had a Health Inequalities Summit, which was very well attended with over 300 people on a Teams call. You can imagine how challenging that might have been. But again, it just highlights the level of interest and actually how having a community of practice can help galvanize the efforts, identify common approaches, as well as providing that channel for advocacy. My last point was more to do with the advocacy work. Is how do we then make the case not only locally but nationally, and utilizing that evidence base. We've started using the data from the DPEN network to really understand the disproportionate resource utilization by populations from these areas, and not through a fault of their own, but a harsh reality of some of the challenges that these patients face. So we have used the data to profile and to look at the average age at which patients start accessing some of our urgent care services and how different it is compared to the other areas. The differences in A&E admission, A&E attendances, emergency admissions, and what that then means in terms of health resource utilization. And we are using that to inform and working very closely with David Chandler and some of the finance colleagues on how that can help us in terms of the resource allocations within the region, but also how that can help us to challenge the national resource allocations. So in summary, the DPEN network is more like a community of practice, bringing together our practices, working with our most deprived communities to really get to understand the healthcare inequalities challenges, but also to work together to find solutions. Thank you.
Thank you, Edward. And why is this important? Because in one of the earlier slides, we talked about how general practice funding is made up and the core funding we described. One of the significant elements of that core funding is based on life expectancy. So those practices with the harder challenges of a deprived population, their financial flows mirrors their patient population and life expectancy. So as you can see, it builds in a challenge for them in terms of resourcing, which was described by Edward. Thank you, Edward. And if I go on to the penultimate slide, Chair, that tries to sum up the whole direction of this presentation, is about where do we go forward for now in terms of building a better general practice. We've tried to sum up a lot of the elements of what's been discussed through the presentation into our key priorities and what we think are our key work programmes, which is neatly described in summary on a page. And it'll allow us to really keep direction and focus going forward from tomorrow. And people then ask me, do we need a vision for primary care, a new vision for tomorrow? And actually, when we look back to the formation of the NHS, it was very clear that the NHS was built as a cradle-to-grave service. And I think we would argue that for general practice, nothing has changed. That actually, in its nature, general practice is the front door into the NHS and is a cradle-to-grave service that provides for all of our population. And I think that's still fitting today and tomorrow. Thank you, Chair.
Thank you, Chair. So that's the end of the presentation. As we said, this was to stimulate some debate and discussion. Conscious we've been through an awful lot there, probably scratched the surface, but I think this was the opportunity for people who have more input into this to help design the way forward that Joseph described. So thank you to colleagues for helping with that.
Okay. Well, thank you, everybody. That was an excellent overview, and we'll get started on the discussion. Before opening it up more generally, ask, as I mentioned at the beginning, our GP members to perhaps a few reflections. Mike.
Thank you for an excellent presentation. I think that really well summarised some of the challenges and opportunities that we face. I think it's fair to say that the public at the moment are less satisfied than they have been historically with the availability of appointments and perhaps even on some occasions the quality of the experiences that they have. I guess I'd take a turn of the question back to you, Joseph. What do you think is a single thing that we can deliver in the coming years to try and improve the experience the public are having of general practice?
I think it starts with the patient, supporting and educating and empowering them to realise that for a lot of their conditions, they're not wholly reliant on their GP, that actually their general practice has changed, which I don't think they realise. And there is almost a small army of a workforce in each GP surgery able to deliver and support their needs. And then the channel with which they access it, which is not always has to be now on the phone. And many of our patients are very enabled with their bank app and they're ordering through Amazon. And I don't think they realise that the opportunity is to interact with the relevant clinician in their general practice via a similar medium where it's appropriate. And so I think it's supporting the patients in this journey to realise that there's so much more available in general practice. We just need to show them how to open the door to that.
Thank you. Syra.
Thank you, Chair, and thank you, Joseph and Dave, for a very needed and very useful presentation. If I may, Chair, I just wanted to share a couple of observations, please. Just to recap, that obviously we know that primary care in the UK delivers 90% of patient-facing care for less than 10% of the budget. Approximately 8.1% was the last figure that I read. So obviously capital funding is a massive issue, and obviously we know that the System Development Fund is important. You talked about the Recovery Access Plan. When you break it down per ICB, that's approximately 3 million for the North East North Cumbria and spread out across 300 odd practices. I don't need to go into that further, so just something to be aware of. The other thing I wanted to talk about is obviously when you look at the demand of appointments, we are now delivering in general practice considerably more appointments now when you compare to pre-pandemic, and I think it would have been useful just to see that data, because I think it's important that we kind of share with our communities and the public that very much the appointments have gone up in terms of demand, and we're doing that with less GPs, so that's also important to highlight. The other thing I wanted to talk about was obviously we're doing this all with the estates issue, so there's less GPs, less clinical rooms, but more demands, more requests, compared to the patient needs. There's less space to be delivering this, so that's definitely something that we need to look into, and obviously Sam already alluded to that earlier. The other thing I just wanted to touch upon was obviously moving from the reactive to the proactive response, health inequalities, making sure that, you know, preventative care is at the core of everything that we're doing in primary care. But with that, we need to think about looking at how the resources are spread across the NHS system. And obviously, you know, the Hewitt report nicely highlighted that the preventative work means that resources may need to go from secondary to primary community services. And finally, I just wanted to say that obviously the partnership model of primary care is very much holding the ring and keeping everything together. So it's really important that we continue our support to the partnership model in order to help our communities have that continued relationship that they do with their primary care teams, as the GPs really do know what's going on for their patients and are able to advocate for them quite strongly. And the final point I'll make is that whereas we are able to have deficit plans in other part of our system, it doesn't quite work the same in primary care. So I think that's something that we need to recognise, that inflationary pressures are also affecting practices individually, and that, you know, we need to discuss that somewhere. Thank you.
Thank you, Syra. Neil, as a GP, not as our medical director, for
Yes,
one sec.
thanks. So yeah, I mean, it does. I mean, the presentation has covered most areas. I think work as a GP at the moment is difficult, is time pressured. I think we do need to reconsider the role of the GP in the patient journey and where can they really add value. And where can other professionals within the community team do some of that work to allow that kind of value added for GPs. GPs are highly trained individuals, and quite often they are spending a lot of their time on tasks that could be done by other people. I think the way in which general practice is structured and funded is something that I think we should look at and think about, and not close our mind to any particular future form or function, because there's a lot of practices out there that are vulnerable and have quite a lot of pressures put upon them. And as an ICS, I think we need to understand how we support them so that services don't start to be affected for small parts of our population. We need to make sure we are able to look at the practices, each and every one of them, and not just treat our ICS as a whole. But it can be a very difficult but very rewarding job as a GP. And I think most, well, if not all GPs are absolutely committed to providing the best quality care for their patients. But I think a lot of them are struggling to do that at the moment. And anything we can do as a system to support that would be appreciated.
And Joseph, you to take your director hat off and say what the challenges are in your practice and what the dreams are for your practice.
Yes, thank you, Chair. I've been senior partner non-clinical in my practice for 25 years, and general practice has adapted significantly to transform. It now does a lot of work that was done in hospital, especially outpatient work for many of the chronic diseases, and it takes on more and more continuing care as well as the urgent needs of patients that occur on the day. And I think to sustain the model, as Sam described in her report, we only have a finite amount of money, and I think we've got to look at where we invest that appropriately. I think there needs to be a paradigm shift, and we need to work more closely with our secondary care colleagues, because we can help them more and more take a lot of the work out of hospital if they support us and we shift the funding appropriately into primary and community, so that they're not overwhelmed by the demand that they see. So I think collaboration is the future, and I think general practice are up for it. They even though they are all individual units, they are now a mature system partner that will work in collaboration.
Thank you. We'll open it up more generally now. Graham.
Thank you, Chairman. Can I say thank you to colleagues for a very comprehensive and informative presentation. I was really enthused by the number of colleagues that mentioned digital and data. I think that was a golden thread throughout the presentation. And in particular, Edward's comment about using deep end practice data to drive actionable insight and decision, which I think was something that we've majored on a couple of board meetings so far. It was always also positive to see some of the examples of system convergence, utilising interoperable technology, although the graphic with the number of laptops on around the same desk was a little bit worrying, but nonetheless, I think it demonstrates that we are making some progress there. But my view would be that transformation is not about doing the same things better, it's about doing better things, and how we can use this opportunity to work more collectively as a system. Some of this will be what we term a shift left strategy, where we push more control to patients and citizens. And again, Joseph's mentioned that there's already many of our citizens utilising apps for banking, retail, etc. Whereas in health, we haven't quite cracked that yet. Conscious of the fact that as well as the opportunity, there's also a challenge that digital transformation will present itself with some people that are unable to access technology. And there's a major issue with digital poverty at the moment, so we need to be cognizant of the things that we do, that we don't exclude people in that regard. But there's also a tremendous opportunity to continuously reinvest. And I think, if we've got transformation funds which are time limited, we really need to move that paradigm, as again Joseph's mentioned. This is about transformation, and it's not just for Christmas. It's a continuous investment to make things better. So I think there's a great opportunity. During the days of the National Programme for IT, some colleagues may be familiar with that, primary care were one of the vanguards. They did a lot of transformation back then, so they're in a good place, and I think they've got the track record to demonstrate that things can be done in that scale. I was also really pleased to see in the workforce review the use of the additional resource roles, the R's roles, and in particular using the digital and transformation colleagues there. We've already reached out to colleagues that represent the primary care networks to do more alignment with the ambitions of the ICB and the ICS to make sure that where we can invest once and spread that knowledge across our entire system. So overall, Chairman, a really impressive presentation. Thank you.
Sam.
Thank you, Chair, and thank you also to colleagues. Really fantastic and informative presentation. And there's lots of things we could comment on here and have a much longer discussion, but there's sort of two things really I wanted to raise. I don't think we can underestimate the pressure that our colleagues across primary care and general practice are under. And certainly every conversation that I've had, whether it's with our LMC or individual practitioners, the stress in terms of the demands on them in the workplace. So I'm really curious about how we link that to the implementation of the National Recovery Plan for primary care. So I think absolutely Mike's point, you know, we all think about the public and we want to make, and there are opportunities to make improvements there, but we'll only do that if we've got a valued workforce that have their own well-being looked after as well. So I'm just wondering whether or not we need to do anything additional around a recovery plan for primary care and general practice here in the North East, North Cumbria, particularly thinking about the rurality, fantastic ICC model over in North Cumbria, how do we share the practice? But we'll only be able to achieve this if we really nurture and look after our workforce. So what more can we do to do that? Because certainly the messages I hear are a group of colleagues who are under ongoing continued pressure. And I think all of us, not just professionally, but the public in terms of how we care for, how we respect our colleagues and working services is hugely important.
Okay, Sam, thank you. I'm going to get some response to that in a moment, but we'll take other comments first. David Thompson.
Thank you. And again, just echo comments made about the effectiveness of the presentations. And two questions, if I may, but prefaced by the fact that Healthwatch still receives a huge number of issues about general practice and access to GPs. And I think that is, in a way, it's sad, bearing in mind the pressures that GPs are under. It seems to be a bit of a dichotomy there between the two. But the first question goes back to one of the steps of empowering patients. If I could slightly change tack and talk about involving patients and ask to what extent do you envisage revitalising groups such as the patient participation groups as being important in working towards greater cooperation with patients and so on, and their understanding and the issues of what is going on? As a first question, if I may, about patient participation groups, and are you actively revitalising them?
If you carry on, and then we'll get a response to all the points that are made.
The second one, it's about pharmacies. Again, it's integral to the plan that more work will be directed, understandably, towards community pharmacies. But one major national chain is currently withdrawing from having community pharmacies. And I was wondering if this might pose a risk to the longer term thinking, if pharmacy closure becomes more on the agenda, because it is certainly an issue. I know Healthwatch Northumberland is working with the ICB on the potential implications of this longer term. So I was wondering, as a second question, about pharmacy closure potentially having an impact on your longer term plan to redistribute the work which is being undertaken. Thank you.
Thank you. David Perdue now.
Thank you, Chair. Thank you for the presentation. I suppose it was on the back of Sam's, really, in terms of the health and well-being of kind of staff in primary care, but your expansive workforce, and you've talked about lots of enhanced practice. Enhanced practice needs an awful lot of supervision. So it's looking at kind of how we get that right workforce to give you the ability to supervise people. And we are doing some work in terms of a plan for primary care workforce, but it's just your ability to kind of offer that supervision, whether that's through pharmacies, through GPs, but it's a big commitment to that expansion workforce. And we know that from a nursing perspective, we've seen a drop in the number of nurses going into primary care, and it's how we get that as a valuable contribution and workforce joining primary care.
Okay, thank you. Tom Hall.
Thank you, Chair. I just wanted to really reiterate the points that Edward made in particular around deep end practices and how radically different population health need is in some of our deep end areas, and just a real plea for us to think differently about primary care strategy in those areas, particularly linked to the number of social issues that are interconnected with health issues in those communities, particularly around things like domestic abuse, substance misuse, employment or indeed unemployment, and how we start to create better interconnected offers underneath the banner perhaps of public service reform in those kind of communities where actually the general practice or the pharmacy are really trusted hubs of communities, which might otherwise be suffering from kind of gaps in terms of access to public services. So I think there's a real opportunity there for us to think differently about how we resource those areas and indeed what we deliver in those areas.
Thanks, Tom. John Rush.
Thank you for the presentation. I just wanted to emphasise the challenges that general practice face. I know we touched on some of them, but if you think about what they've got to do, they've got to work with other practices, separate businesses sometimes. They've got to work with other elements of the primary care, which we've already just started to talk about, which is pharmacy, optometry, dentistry, etc. They've also got to work within the sort of social care areas as well. And they've also got to work with secondary care. And the point I'm trying to get to with all of that is they're not one organisation. So the challenges in being able to support how primary care and general practice works within that framework should not be underestimated. And I know that's what I think Sam was touching on before as well, and I know others have touched on it. But it's what mechanisms do we use as an ICB to support general practice within that? I know we saw the presentation about ICCs, and I think that supports some of the elements around how you work within social care, how you work with secondary care on the ground within the community. But I also think there's other things to mention as well. You've got, for example, hospital pathways, which helps work with secondary care, whereby that creates the connectivity between consultants in hospital and general practice on a really formalised basis, and how do we expand that? But the other side of it is how do we support practices when they get in trouble, which I think was Neil's point as well. And get in trouble they will. And I mean, we've had experience of it when I was involved in North Cumbria, and if you leave them to say it's not our job, then that's not the right approach either. And you have to get involved, but that takes time and resources and expertise. And one thing that it does do, if you do it properly, is it builds confidence and trust, which for us as an ICB, which I know that Sam is very keen to do as well, is how do we get confidence and trust of the providers providing the service? And that's one of the ways that we do it, that we don't step back, we step forward. But that takes resource to do it and expertise. So I wanted to sort of say those things because I think it shouldn't be underestimated, the challenges that they're facing.
Thanks, John. Annie.
My comment, and again, thanks for the presentation, was linked to Tom's really and the opportunity within the deep end practices, Edward. So my question was for you really around, you mentioned the training and the importance of that, but gaps around QI capability and what opportunity we have within that community of practice of doing something quite radically different in supporting the development of working with patients and communities in different ways to deliver change for our population.
Okay, thank you. And then Mike.
Thinking about the various aspects of transformation has caused me to reflect back on a meeting we had in the depths of the pandemic, and Joseph was in attendance at this meeting. And it was a meeting of primary care directors as we were planning for the vaccine programme and the very first day of the vaccine rollout. And in this meeting, everyone normally has a lot to say and lots to contribute. But there was a moment of stunned silence as we all just, I think, reflected on the task we had ahead to get this campaign going. And I think what that's made me think about is that transformation is exhausting. It's really stressful, and it took a lot out of all of us to do that. But at the same time, primary care are up for it. Primary care, general practice want to make things better, want to improve, but we have a certain amount of capacity to put all of that energy into it. So it really is important that we choose the right things to focus on to transform.
Okay, we'll get some... sorry, Ken, yes, please.
Three quick comments from me. Given by the range of questions and comments you made today, you realise how complex an issue this actually is, and there's not just going to be one solution. I'm afraid it is very complex. Talking of complexity, I reflected on the Bob and Sue diagram just for a second, and I wonder whether we ourselves have made this system far too complicated for patients to understand. And I worry a little bit about all the additional roles, descriptions, titles, and all the other stuff the NHS uses every day, whether actually that's made the system for our patients just much more difficult to navigate through, because there's so many bits. There was about 500 different contacts on that Bob and Sue, and actually 3 of them I think were in different geographies in Cumbria. Wigton, I think, was mentioned for example, yeah, in 3 different bits. So I think the complexity is something for us to reflect on as well. In trying to do the right thing, actually, are we making it worse? And then the third thing, echoing John and others' comments, I do think there's a real role for secondary care here as well to re-engage properly with primary care. I think we've lost that link, undoubtedly true. This is a general comment I'm making, but certainly in my own areas in Sunderland South Tyneside, it is something we can absolutely get our places and neighbourhoods to focus on re-engagement to get the pathways sorted clearly for our population. Thank you.
Okay, thank you. I think we get some responses now to that. I'll just add my few things on. Most patients I talk to, one of their biggest concerns is lack of continuity of care, partly shaped by the fact that the GP workforce is much more based on part-time practitioners, as was the case in the past, but people don't get frustrated when they have to explain their problem again to another GP and then another one, and that's quite common, certainly in the people I spoke to. The second thing is waiting for diagnostic tests, and the question asked, well, why do we have to have an outpatient appointment first? Why can't my GP do it? So the answer to that question. And then a more recent bit of reinforcement of policy, I think, coming from NHS England, that patients are to be given 5 choices when they're going to be referred. Sam might want to say more about that later, but that was an existing policy, but it faded away. And I just wondered what the repercussions of that would be, and how wide the 5 choices are. And, for example, whether a patient with a problem could go to Bart's Hospital in London, or whether we're restricting ourselves to the North East, and what the implications would be for contracting and commissioning. Let's work our way through. Some were comments and not questions, so those were well received. What we can do for the workforce. So Dave, Joseph, Neil, any quick thoughts? So we've got half an hour, so shorter responses if possible.
Yes, so the supporting the general practice workforce, I think one element of the workforce that is very undervalued and probably it's the hardest time is receptionists, and they are the largest part of the core general practice workforce, and they are the gateway in for patients. You can imagine what a tough time they're having, wrestling the expectations of the patient along with supporting their GPs and other clinicians so that they don't get overwhelmed. So this came up at a conference that Dave and I were at, that there is a move now nationally to widen the staff survey, the NHS staff survey, to include for the first time general practice staff. It looks as though that's going to proceed, and I think that would make practice staff feel more valued, that they are part of the NHS, being part of the national survey. It'll also give us very distinct data nationally on what are the key things that are impacting on them. So I think that's a good step. I should also say that we've already got initiatives underway, and Sunderland is a good place to quote, where they are rolling out the Better Health at Work initiative. It's an initiative that many ICB staff are familiar with, but not as common or accessible for general practice staff. And that allows practices to nominate champions within their practice to focus on issues that are around, say, male health, mental health, and other initiatives, so that practices have got the opportunity to think inwardly about the things that they don't normally have time to think about around staff and their well-being. And if I wrap around the workforce question, the question around practice nursing and and clinical supervision roles. We do have a number of initiatives that are funded from the SDF system development funding we talked about that are looking at supporting GPs and other professionals to take time out to mentor the plethora of roles that are coming in who all need supervision. So that's the start, but by no means covers all the professionals. And so it is hard work. And of course, if we're drawing clinicians out to do mentoring, that's so many less appointments. They're not seeing patients. So it is something, it's squaring the circle is a tough challenge. Around practice nursing, we do have good examples around the ICB of a career start practice nursing scheme that encourages nurses from other parts of the NHS sector to come and almost retrain, because general practice nursing is very different to hospital-based or community-based nursing. And I think there are good examples we can look to.
Dave, do you want to add anything?
Yes, thank you, Chair. One of the things that a number of people have mentioned, and it's not the workforce per se, it's the space for the workforce. Because as we're bringing on new roles which are valuable, that really help, it's having the space to actually accommodate those people and equally accommodate training for the general practices. So there is a piece of work that we've started just to speed up the process for improving estates, because it does take far too long. And inevitably what's happened in previous years is by the time the application is complete, it's too late and the money can't be spent that year. So there's a piece of work we've started with NHS England to actually improve that flow. There's also another piece we need to think quite carefully about, and that's when we talk about capital. A lot of the capital goes to secondary care. Huge amounts, huge hospital schemes. Actually, we could try and move some of the capital funding away from just a small amount from secondary care to enable more practices and other community services, because this is not just about practices, it's about practices working within communities to give more space for colleagues to work in, which would again take some pressure off the current workforce.
I think for me, there's something about listening, and we do quite a lot of that, listening and engaging with the workforce. And I think, and in listening, acting as well on some of the things that we can make a difference on, in reducing some of the bureaucracy, for instance, that it has little value added. So I think those would certainly improve confidence in a lot of the workforce in general practice. The second thing I think is public communications. I think quite a few GPs feel persecuted in the media over the last certainly 6 to 12 months with quite a lot of negative press. And I think there's something we can do to maybe promote the positive aspects of general practice. And I think that would also help our workforce. If the public lose the confidence in their general practice, then everybody suffers in that, because patients will try and access healthcare in very different ways, which will put greater pressures on other parts of the system. So I think I think supporting GPs in listening, reducing bureaucracy, and supporting their core purpose, which is about that cradle to grave care for their patients. They act as navigators for their patients in very complex systems, and continuity. I absolutely agree, Liam. We need to get back to that way of working where the GP is a specialist in complex community medicine, and they act in a way in which they understand their patients and the pressures that are on them. And there's quite a lot of time spent on things at the minute that are really not that value added, where GPs can have much greater impact in doing the kind of things that you've mentioned. So there's a lot to do.
Sarah and Mike, any thoughts from you looking at it from your perspective?
Yeah, Chair, it was just touching upon your comment or question about the GPs working part-time, multifactorial, but just as Dave was saying, supervision plays a key part of enhancing the workforce within primary care. So a lot of the GPs that may be perceived to be part-time are actually doing additional portfolio roles that are contributing, be that working in secondary care as associate specialists or being trainers for medical schools. They carry out a plethora of other roles as well. So they're technically not part-time GPs, they're just GPs doing a lot of wearing a lot of other hats.
Mike.
Yes, I would echo that, sitting here today as a GP but not seeing patients. I think, as Neil alluded to, really there is going to be a big transformation in what the role of a GP as a professional is doing. And then we do need to bring the public along with us in that and to make sure that GPs are doing the thing where they're needed most. I think that's a really important, bringing the public along with us is a really important part of that, to try and keep morale high.
Okay, thank you. Running down the other list of points that it would be good to just get a bit of a response on. David's point on patient involvement. Joseph or Dave to comment on that?
So we're actually today in Durham, so I'd just like to use the Durham example because they've looked at this exact question about how we can refresh patient groups so their contribution is meaningful. And with the changing landscape of the development around neighbourhoods, firstly with primary care networks evolving to integrated neighbourhood teams, they've asked their practice patient groups whether they can actually create representations around their neighbourhood populations and have developed primary care network patient groups. So that actually, rather than just looking at the problems associated with their practice, a lot are common around their actual population, their neighbourhood and village. And at Place in Durham also, they've now refreshed how we can bring that commonality, what patients bring, and also that richness of what's individual to a bigger forum. And so they've now created a place-based patient participation group. And I think Durham's a good example of how it's actually adapting so that patient voice isn't lost within the changing landscape.
Okay, thank you. The community pharmacy closures.
Thank you. Yes, a very important question there. And yes, I would agree. It is a risk. We are bound by a national contracting model and a national funding model. And large chains will have their own ways of working, which may be slightly differently aligned to ours. But what really made me think was John's contribution earlier about general practices and when they're in trouble and whether we know about it. And whether it should be the right thing that when a community pharmacy is in trouble, the first thing we hear is we're closing. So we need to think about that. And from where I've sat, sometimes that engagement isn't always there. There's an element of suspicion on both sides, from our side and from the chains. And we need to work out how to engage them in some of this, both for the development work that we want to do, albeit now national, and also for some of the closing. But workforce, again, is a large risk in community pharmacy, making sure that we have sufficient numbers of pharmacy professionals and support staff to staff them, because we do have unplanned closures in addition to the closures that are announced, and no doubt one will impact on the other. So much to think about.
Thank you. John, your point was broader than I'm going to raise now, but it did include it. We've got a very well developed system for dealing with hospitals that are performing poorly, both nationally and at the ICS level. Have we got a system for helping, intervening in practices that are performing poorly, Neil?
Yeah, in short, I'd say yes, we do. I think if we were to look inwardly, I think we could do better at intervening at an earlier stage. Often it's triggered by a crisis. And I think there is, it gets back to our intelligence and data around how we could maybe spot a practice that is starting to struggle at an earlier stage. But we have embedded within all of our places place-based clinical leadership structure that understand the practices that are within their patch, and often we rely on soft intelligence that will give us some of the early heads up. But I think there are a number of metrics that we could look at and do look at relating to quality performance for practices. But I think there is, again, more to do on that. We hold masses of data and information about practices in the way, in not just their access, but in some of the outcomes for major health conditions that we could start to use in a more intelligent way to have a supportive approach to practices that have maybe got some early warning signs that they are struggling. And I think that's something we've tried to do in the past as CCGs, but I think it needs more development that we could do to stop the practice getting to the point where they are at the point of failing.
Thank you. Dave, you want to add on that?
Yes, thanks, Chair. Neil's right. There's lots of data there. I think the other key bit that we need, and it's probably Sam's point about support, is actually the day-to-day relationship with practices or indeed with pharmacies, as we've just heard. Because if you've got that relationship right and the trust's there, then you'll actually get people raising concerns before it becomes too late. Because again, Neil's right, there are a lot of occasions in the past where it's been beyond the point of no return and it's taken a lot of time and effort to support practices. If we can get in there early doors and have the conversations, understand what's there and support them, and get other practices to support them, because there's quite a bit of mutual support between practices we've seen, particularly over the last few years, we'll be in a better place. So it's data, but it's also the relationships and the understanding that we need with the providers.
And Sam, restoring the rights of patients to have a choice at the time of referral.
Yeah, thank you, Liam. So patient choice has been a national policy for the last decade. So nothing's changed there, but certainly during the pandemic, it wasn't being enacted in the way it previously was. Therefore, NHS England has set out a commitment, particularly as part of the elective recovery plan, to ensure that we are opening up choice for patients. So this will be across all specialties, hips, knees, eyes, and it'll be enabling patients to have choice of provider. Now, we have got work to do over the next several weeks in terms of how we can meet the criteria, particularly of enabling patients to have a choice of 5 places where they could go to have their procedure. And also, there's a new requirement now, which is people who've been waiting 40 weeks or more also can self-select where they go. So the patient choice policy, Chair, has enabled patients to choose their provider wherever it is. That has historically been the case. I think what we do know, though, particularly with our work on elective recovery here in the North East North Cumbria, is people, whilst they will exercise some choice, particularly where we've had mutual aid and offered people the opportunity to have their procedure at another hospital, particularly where they've been waiting longer. A lot of people do opt to wait, actually, for their local hospital, but we'll be working over the next several weeks with our provider collaborative and colleagues on how we refresh our plans and make sure that we meet the national requirements.
Thank you. And Joseph, Tom's point about the practical needs of patients in some of the most deprived areas, which are beyond what would normally be a general practice service.
Yes, so interestingly, we do have work, and we have an example in an ex-mining village in Horden that's particularly got a concentration of deprivation and targeted within the deep end graph that you saw earlier, where where fire, police, local authority, general practice, community, social prescriber link workers have come together to form a hub. Interesting innovation actually describes what John and Tom have been talking about around some of the patients coming into the GP doors is the wrong place, and actually creating the hub allows somebody to get under the problems of some of the patients, which are usually now socio-economic or social. Last week, there was a homeless person that kept accessing general practice frequently, but when they got underneath the problem was every Friday when they collected their benefits, they were actually getting attacked and their benefit was being taken. So they had no funds to live anywhere, and that's why they were living from their car. So that was the real issue that needed addressing. So I think we've got a good example there, and I think it's about targeting those populations where we need to broaden that approach.
Thank you. Neil?
Just to add, the Deep End network is there's a national initiative on this, and obviously we've got our Deep End practices through the Healthier and Fairer work stream. Then we have secured funding for them because it's understanding what the particular issues are for that population, because they are not the same across all the Deep End practices. The issues, I mean, Joseph's given a couple of examples. So it's giving those Deep End practices some freedom to develop local action plans with some additional resource and the support of a community of practice approach and learning from each other, which is hopefully where we'll make some of the impact.
And then, thank you. And Ken's point about complexity and Bob and Sue in Carlisle, what should we be doing to sort out the pathways so that they're simpler and more direct?
Neil and I are working together. Some element of it is unnecessary bureaucracy that takes the focus away from patients. And that's an initiative that Neil and I are working on towards the autumn. And the other is when we described the report from Claire Fuller and implementing that in terms of the development of integrated neighbourhood teams, is how can we, if you looked at that Bob and Sue map, there was adult social care, there was rehab, there was occupational therapy, there was a voluntary sector, but actually if we bring all those people together and have a conversation about when a patient enters the system, how do we make the correct assessment, and then how can a professional with a shared budget have the autonomy to be able to make decisions and therefore reduce maybe 4 or 5 different professional visits. And I think if we can develop those conversations at neighbourhood and place, we can then improve the pathways so we don't have this recurring problem that Sue encountered with her husband Bob.
Okay, thank you. David, you had your flag up. You still want to comment?
Thanks, Chair. It was just maybe two quick minor points, if that was okay. So the first one was on space and estates. And just to make the point that if we have a health building that we're responsible for, we are responsible for a lot of them as an ICB, quite often that space is empty, we pay for it anyway. So there are opportunities about how we can extend space to primary care because we pay for it anyway. Okay, and the second one was on Deep End and the inverse care law, and I'm aware that other parts of the country now are looking about how they fund general practice to take account of that and collectively coming up with a better formula or adding on to the formula. So I got the sense there from Joseph there was like an appetite to do that ourselves as well, to look at that, how we could do that.
And then have we just a general impression on diagnostic tests, what proportion of our GPs can order a cardiac ultrasound, an MRI scan, a CT scan directly without necessarily going through outpatients, except when it's necessary to do that?
I mean, I could probably answer that. The answer is there's variation across the ICB, and I've been working with the diagnostic network to get a full understanding of that. There's both variation in the types of tests that clinicians, GPs can access across the ICB, and there is variation in the waiting times that clinicians experience, even if they're requesting tests urgently. So it is an issue that we are aware of. We've got an active piece of work with the diagnostic network and engaging with our FT providers because they're the ones who are providing a lot of these diagnostic tests. Of course, there's the initiative of the community diagnostic centres coming on, and that will hopefully improve some of this. But there is variation. Some of it is warranted, some of it is unwarranted variation, and I think we just need to understand that. But we could bring something back to a later board.
So then to Dave and Joseph, are there any other points that were raised in the discussion that you feel we haven't responded to?
Yeah, so just on building on the point that Neil answered earlier about continuity of care, I've got to say that the digital record does go a long way in supporting continuity of care. So in the old days, when my father was a GP, if he went on holiday and a locum GP came in, they would have to spend a good amount of time going through a huge Lloyd George record and going through the patient history to have an understanding before they could actually see and treat the patient. Well, now, if it's not always your GP that sees you as a patient, the professional that is there has access to a very comprehensive patient record. The general practice patient record is one of the best in the world in terms of primary care record keeping. And 80% of the presenting condition is there in the last 20% of the record. So it gives the clinician the ability, if it's not always the same clinician, to support patient care in a much more meaningful way with that kind of access to the patient history.
Dave.
Yeah, thanks, Chair. And probably more reflections on the conversation than any areas we haven't picked up, if that helps. Really helpful discussion. I've noted down, obviously, there's a need to support practices going forward and transformation is a big thing, but I think simplification is part of that very much. I also wrote down, sort of halfway through the conversation, general practice is a team game. You know, so we've talked about it not being just about the GP, it's about the wider support within the practice, but actually it's also about the wider team that involves secondary care. And some work that we'll need to weave into this is that interface with secondary care, the joint working, particularly the diagnostic access, but other parts of it as well. And the last bit for me really is the piece about, we talk about patients and there's a bit about patient groups, but actually there's the whole public piece in terms of keeping the public on board, supporting them, but actually keeping them up to speed with what's happening in primary care. Because talking with friends and family, you hear stories about, well, I can't get access to this, I can't get access to that. And actually, in some cases, they can. So there's a bit about just keeping people up to speed with, not to navigate the way around the system themselves, as Ken was suggesting, but actually help. This is the door into primary care, into general practice, and then we'll do the navigation for you and get to the right place first time and as quickly as we can. So lots of good learning from the conversations, which will be woven into the work that Joseph and the team are picking up.
Okay, well, thank you again to Dave and Joseph in particular, and your colleagues who also participated, for giving us such an excellent and deep dive into primary care. And thank you to everybody for the discussion. There are a lot of points that we will be able to follow up on, and we'll be able to revisit this subject in the near future and hopefully report quite a bit of progress. So thank you very much indeed. It's a very, very important part of the service that we provide to the 3 million people, and it needs to be the best, and it measures up very favourably to other parts of the country already. So it's making the good great, I think, what we're looking at. And so we've got a break now, so we'll finish now and resume at 1:45. Right, we are resuming the meeting of the North East and North Cumbria Integrated Care Board, 30th of May 2023. And we're on now to item 9, which is the integrated performance item, and starting off with Jacqueline Myers on the integrated delivery report.
Thanks very much. So I'm pleased to present this month's report, and I know you'll all have read it cover to cover, extensive though it is. So if I may, Chair, I'd just like to draw out a few key points. First of all, to note the revised format of the main report, which I know has been promised for some time. So hopefully folks will find that more intuitive and straightforward to identify the issues, but as ever, happy to take any feedback on the format. But it's quite a significant shift, I think, to the way that the both the dashboards are presented, but also the narrative that's provided in support. In terms of things that have changed since the last time we met as a board, just a few key points to draw out. The board will recall that nationally the NHS in England has what it calls a tiering system for key performance metrics, and that's where they identify organisations within NHS England that have particular challenges in relation to either long waits for elective care or indeed for cancer care. And there are two tiers, tier 1 being the areas that need, the organisations that need the most support because they have the poorest performance, and then tier 2 being the next step down. So we've got some good news in that regard, and that 2 of our trusts have made sufficient progress that, having been identified as requiring support under the tiering system, they've moved out. And those 2 organisations are County Durham and Darlington Foundation Trust, who received official notification that they were moving out of the tier 2 system for their elective care. And that was in recognition of the significant improvements they've made to the length of waits, particularly in terms of meeting the reduction of patients waiting over 78 weeks, which you'll recall was the key staging post target for long waits during 22-23. And then Newcastle upon Tyne Hospital Trust have moved out of tier 2 for their cancer waiting times, again in recognition that they've made real substantial improvements in terms of particularly the number of patients who are waiting over 62 days to get either a diagnosis that's benign, or if they have got a cancer diagnosis, to start their treatment. In terms of other key performance things to note in the report, you will see that we've seen a slight deterioration in the performance against the 4-hour target for patients attending accident and emergency departments, and that's both an absolute reduction, but also we've seen our ICB's performance relative to other ICBs in the country deteriorate. So whereas we were 8 out of 42 in the previous report, we've fallen down to 14th, which drops us into the interquartile range in terms of how ICBs across the country are doing in relation to their performance against that 4-hour standard. Having had a look at this with our providers, we do believe that this is a concomitant impact as a result of all of the work we've done to improve the position in relation to ambulance handover. So board members will remember from previous reports that over the winter period into the spring, we took significant action to reduce delays for ambulances arriving at A&E departments to hand those patients over to the care of the hospitals. And we've seen a really significant reduction in those delays, both in terms of the numbers of ambulances that wait over 30 minutes, but also the total numbers of hours lost to the ambulance service while they're waiting. And we believe what we're seeing is a bit of additional pressure inside A&E departments as a result of that. That's something that we're picking up through our arrangements, working with system partners, principally through the Urgent and Emergency Care Network Board, and something that we'll be focusing on in coming months, so something to keep an eye on. In better news, for the first time in the month of March, all 8 of our acute hospital provider trusts met the faster diagnosis standard. This is the standard that patients on the urgent cancer pathway should get their diagnosis within 28 days of referral. We actually achieved 81.9% as an ICB against the 75% standard. It was also the first time that the 75% standard was met nationally in England, but particularly strong performance here in North East and North Cumbria. I'd also just like to draw attention to the closing position at the end of March in relation to the elective long wait targets, Chair, if I may. And so you'll remember that we were still had a number of patients who were waiting over 104 weeks or 2 years for treatment within North East and North Cumbria. These are principally patients who are waiting for complex spinal surgery, although there were also a small number of corneal transplant patients. As a result of the challenges we've got, particularly in the spinal pathway, the plan that we agreed with NHS England for 2022-23 was that we'd have no more than 30 patients waiting by the end of March. And we actually did slightly better than that, and we had 21 patients waiting at the end of March. And then the next step along the recovery plan for electives is to eliminate patients waiting over 78 weeks, which is a year and a half, perhaps in easier parlance. And again, recognising some of the challenges we've got, the plan that we agreed for 22-23 was to have no more than 180 patients waiting by the end of March over 78 weeks. And we ended up with 163. So again, slightly better than the plan. And that was despite, colleagues will recall that we did have 2 sets of industrial actions since the last time we had a board meeting, and that did have some impact on those long wait patients, but for the most part we were able to mitigate that and then recover by rebooking those patients pretty rapidly. Just in terms of a couple other bits of interest to draw out from the report, NHS England has now introduced a tiering process for urgent emergency care, and that's been implemented since we last met, but I'm pleased to report that none of the organisations in North East North Cumbria have been placed into either the Tier 1 or Tier 2 support arrangements for urgent emergency care, which I think recognises our relatively strong performance in that area. Just a couple of other things then to note. We've been made aware that there'll be an assessment of the ICB's performance undertaken for 22-23, but that will be something that's done on the basis of a sort of narrative assessment. There'll be no sort of standards awarded this time round. So that assessment's currently taking place. It's on the basis of our annual report. We've been asked to share our draft annual report. That will be coming forward to the next board, I believe, Chair. And in due course, when the annual report is finalised and that assessment is complete, we'll obviously share the outcome of that. So it's going to be in the form of a kind of narrative commentary on our performance in 22-23 from the NHS England North East and Yorkshire regional team. I think that's everything I wanted to draw out in terms of the report. I have had one query which I'll take up front, which is to say on page 59 of the report, you'll see that we're now including, as we saw earlier in the primary care presentation, a table that shows the CQC ratings of all of our practices in North East North Cumbria. And then further down on that same page, we've given a roundup of the ICB performance against the measures in the National Oversight Framework. And I think it's been pointed out to me that the final column in that table perhaps is not as clear as it could be, Chair. So just to explain that, if I may, where it describes the number of metrics that are compliant or not with the national standard, and that's a smaller number than the number of metrics that are described. That's because not all of the metrics in the oversight framework have an absolute standard. There are a subset of them that are simply measured relative to other ICBs or other organisations in NHS England. So what that final column attempts to explain, and I will seek to make this clearer in future reports, so grateful to my colleague David Thompson for pointing this out, is to give you some sort of absolute measures as well as some relative ones, but I think we can probably improve the explanation of that table in future reports. Thank you, Chair.
Thank you. Any comments or questions on this report? David?
And thanks for a comprehensive report, and it's assuring that in the executive summary there are a significant number of improvements being recorded, and there's a lot of positive stuff in there, and I think we tend to sometimes forget the amount of very, very good work which is taking place. And thanks for illuminating us on that metric on page 59. I just couldn't understand it at all, so excuse my ignorance. But 2 comments, if I may, on the report. On page 54, it mentions the bed occupancy rate of 91.5%, and that has been consistent from last November and from January of this year. And I know that people staying in hospital for no good reason has improved of late, but that seems to be a stubbornly high figure with all sorts of implications on staff pressures, challenges, on patient care and indeed patient safety. So is that a static figure, or might we see that going down in the future? And the second one was on infection control on page 56, where MRSA, C. diff, E. coli, it seemed to be worsening. And I was just wondering, although the numbers are not great, it's not high profile. Once numbers start to increase, it's not so easy to bring them back down again. So is that a risk which we need to look at more carefully in the future? Thank you.
I'll start if I may, Chair, and then I'm sure David will want to come on the infection control question. So, I mean, in relation to bed occupancy, you're absolutely right, David, it's pretty stubbornly high. Historically, if you like, the bar that has been suggested as a sensible aim for bed occupancy has been 85%, and as you say, ours is hovering around the 91, 92%. It's by no means the worst in the country. We've got some parts of the country that are up at 97, 98%, but it nonetheless, it does result in some pressure. I think, by way of explanation, why it doesn't shift a lot is that whenever we do see a bit of improvement, as we did in the spring, around reducing the number of patients who are awaiting a transfer of care out of the acute hospitals, we tend to then see a concomitant increase in the elective activity that goes on because we've got that very large waiting list. It's worth noting that in terms of the operating plan requirement this year, it's been set at 92%, which I'm sure some colleagues will think is higher than it should be. So our plans, if you like, are to maintain bed occupancy at around just short of 92% across the next year. So I don't think we'll see it move significantly from that sort of level over the course of the year. But I think it's something that we will continue to pay attention to, and a bit of work that we're doing in the background also is to try and make sure we've got a meaningful measure of bed occupancy, because it's quite a blunt measure. It includes all general and acute beds mixed in together, both the ones that are used for emergency care and the ones that are used for elective care. And they're not always, and obviously within the bed base there's some quite specialist beds, even though they are within that count. So it's not always the most helpful measure in terms of understanding the level of pressure in the bed base in the hospital. Thanks. I'll defer to David in relation to the plans for addressing the infection control.
Thank you. Great question, David. So we've already undertaken 3 deep dives in individual trusts to look at kind of infection control, process and control for that. So we're looking at the learning from that. So that will be presented at the next Safety and Quality Committee because we picked it up at the last meeting. In terms of the MRSA, so there's 4 cases, but involves 3 patients. All of them were very well known in terms of the organisations. So we've taken, say, a root cause analysis of all that, and we'll share the learning from that as well.
Just sticking with that for a second, the acronym IPC, Infection Prevention and Control, meaning in healthcare facilities, has got a much, much bigger profile internationally now, partly because of the amplification effect of pandemic viruses in hospitals, and Ebola particularly in West Africa, COVID we all know about. So and I think certainly back to the patient choice issue, if I was given a choice of 5 hospitals and one of them was off the scale for poor infection control, I wouldn't go there. And I think every patient should look at that before they make their choice and choose somewhere that's cleaner. I think that's one of the purposes of being able to use statistics in that way. Anyway, are there other points that people want to raise on Jacqueline's report? If not, thank you very much. And over to David for the finance report.
Thank you, Chair. So 2 reports today for you. The first one presents the financial outturn results for the financial year just gone for both the ICB and the ICS, obviously subject to audit. I'll pick on the 4 main financial duties relatively briefly. Chair, just take us through them. First one is for the ICS to break even as a whole, as a collective. By that I mean the ICB and foundation trusts. From a financial perspective, members will recall that we agreed the back end of the year to amend our forecast outturns, but that would still leave us achieving a modest surplus for the end of the year. The ICS has reported a surplus of £58 million. That's actually made up of three parts though. So the first part is the achievement of that modest surplus I've just mentioned. The second and third are technical surpluses or issues. The first one is a technical surplus at Northumbria Foundation Trust. That relates to a building rectification legal dispute, and that was settled at the back end of the year just gone. And the third one was in relation to South Tees, where they have a 1.4 million deficit against plan, but that was wholly related to the non-consolidated pay awards that they have to pay to a subsidiary. They're not funded for it, and NHS England have accepted those two technical adjustments. That doesn't put any risk against the ICS being deemed to have achieved its financial duty of break even for this year. That's really important because that brings not only credibility to our system, but also brought in £17 million of additional capital resource for the ICS, which I'll touch on later on the next report. The ICB has a duty to achieve its plan or break even on revenue. We achieved a small surplus of £2.7 million. That offset a provider side overspend of £2.7 million. There were pressures in independent activity on the acute side of things. We did actually receive some funding for that from NHS England late in the day. Prescribing cost concessions, which have been mentioned earlier today, of around £20 million, were also a pressure in the year, and they were offset by other non-recurrent slippage and savings. But overall, we achieved the plan that we set out at the start of the year. Last two, capital. You can see in the paper that we achieved a small underspend in our capital programme. We were forecasting a reducing overspend month on month. In the last report, I had a £5 million forecast overspend. We actually brought that down to a £7 million underspend, and that was on the back of some new hospital programmes funding for the Cedars development at CNTW. We were actually expected to have a bit of a surplus once we received that funding as well, so that was a planned surplus of £7 million. It wasn't a missed opportunity or anything. A touch on running costs. They were under by about £5 million, just more than £5.5 million. That's been a trend through the year. Actually, that's quite important given the running cost reductions that we've got coming in the years ahead. So, final points on this paper, Chair, before any questions. First of all, this is obviously subject to audit, both in the Foundation Trust and the ICB, going through audit processes now. I would just mention that the CCG accounts, we've got 8 CCG accounts subject to audit this year. They are just for 3 months. And because of that, it creates for us what we call a materiality issue. Because our accounts are basically audited on their balance sheet. The balance sheet is about the same as it normally is, but materiality is a quarter of the sum that would normally be because we're only 3 months of accounts. So that may create the odd issue here and there that will no doubt come to audit committee and the board if materiality is affected by that in terms of our accounts. So just be aware of that. It's actually a national issue as well. It's not just a local issue. And the two other things I'd just like to mention. One would be, I think it's really important to thank all ICS partners in terms of achieving those financial duties, subject to audit. Not just Foundation Trust, but I think all partners have played their part and has been able to achieve that. So they were the last two things I wanted to mention, Chair. Happy to take any questions.
Thank you. Are there any questions or comments? If not, David, we'll move on to the... Oh, so sorry, David. Go ahead, yes.
Thank you.
Can you come a little bit closer to the mic?
Okay. Final one, actually. On page 102, paragraph 34, there is a very important sentence which says the position includes an extremely challenging efficiency requirement and presents substantial potential risks to delivery. It's a small sentence, but a big meaning.
David, sorry to interrupt. I think that might be the next paper. Yeah, it is. That's okay. Yeah. We could move on to the next paper, which very much covers the ground that Sam was touching on earlier in her Chief Executive report and how you've been working hard to try and get the deficit as low as of all ICBs across the country.
Absolutely, thank you, Chair. So the purpose of this second paper is to ask the board to consider and approve both the financial plans for 23-24, but also to ask for delegated authority to approve the contract values over £13 million for those of us who aren't conflicted. That's there because the scheme of delegation only delegates authority of up to £30 million to the executive committee. So contracts above that value come to the board for approval. So I hope the paper itself provides a helpful overview of the process we've been through and the outcome of what has been fair to say, a very challenging round in terms of producing a plan that NHS England were willing to accept. An awful lot of work has gone into producing the plan with all partners, especially NHS partners, over the last few months. And I do think it's extremely important to acknowledge, first of all, the challenging nature of producing a balanced plan, which I'll come on to in a second, but also the hard work and efforts across our ICS community in terms of being able to produce a paper for you today that incorporates a plan that has been acknowledged and effectively accepted by NHS England. We have gone over the draft plans that have been submitted in previous board meetings, and I trust those meetings, coupled with the paper today, provide you a comprehensive overview of the process and the plan. So that being said, I'll just go through maybe the salient points within the plans and then go to any questions. So if I start with the ICS plan in its entirety, which from a financial perspective includes Foundation, Trust and the ICB. I appreciate the ICS is wider than that, but from a financial perspective, that's what it incorporates. So we have a budget of £7.2 billion. Our draft plan that we submitted in February was a £410 million deficit. We got that down from March to a £195 million deficit. And on the 4th of May, we submitted a £49.9 million deficit plan. Obviously, we'd prefer to submit a balanced plan, but we were able to get to 49.9. That has been received and acknowledged by NHS England to be in line with their expectations given the challenges that we face, which I'll come on to in a second. It did include £18 million or just over £18 million of funding from NHS England for excess inflation pressures. It does incorporate a collective FT deficit plan of £82 million, which I'll touch on in a second, and an ICB surplus plan of £32 million. So collectively, they add up to £50 million or so, that being 0.7% of our total income, just to give you some context there. Sam's mentioned some of the pressures that have led to us only being able to pull together a deficit plan rather than a break-even plan. I won't go over all of them, but some of the challenges are in the paper, but they include things like our allocation growth being approximately £20 million less than the average in England. Our pay award for 22-23 wasn't recurrently funded in full. That was another £20 million pressure. COVID funding was reduced this year by £100 million. Sam mentioned earlier convergence funding reductions of £100 million over 2 years. I could go on, but there were a number of financial challenges which made it very difficult to come up with a balanced plan this year. That also meant limited investments. The main thing we probably invested in this year, if you go through the plan, was investing into 999 ambulance services and ensuring that response times are in line with national expectations. In terms of some of the impact of the financial challenges on the plan, we see the average cost reduction now in a foundation trust of around 4.5%. Sam mentioned it earlier. I think it's just really important to reiterate that most organisations would deem 3% to be the top end of what could be reasonably achieved in a year. And the reason I mention that is because 4.5% is a challenge for all those organisations. 3 of our foundation trusts have underlying deficit issues. They total £100 million or just less than that between them. Our other foundation trusts are either at break-even in their plans. One has a planned surplus of £12 million. And the reason I mention that is because if you recall last year, a number of our FTs were able to produce a surplus. and that offset deficits in the others. We are not in that same financial environment this financial year as we were last. So they're the main reasons why we've not been able to collectively get to break even, but we have got to £49.9 million. That has been through a lot of scrutiny by NHS England, a lot of individual reviews by NHS England of individual organisations, and we have got a plan that has been acknowledged as being where the NHS England think we can get to this year. For the ICB, I mentioned it's a £32 million surplus plan. That includes almost £100 million of efficiencies. And for context, that's double the amount of efficiencies that the ICB identified and achieved last financial year. That obviously comes with risk, which I'll touch on in a second. It also includes slippage on SDF funding and a few other commissioning budgets of around £20 million that we expect through the year, as well as an additional £15 million of additional anticipated elective recovery funding, because we are anticipating, or were at the point of plan, that we would achieve more than the national target on elective recovery. I mentioned risks. I think it's really important just to talk about those risks. You'll see in the paper identify £250 million of unmitigated financial risk, which is basically £50 million in the ICB and £200 million across foundation trusts. In a good year, you'd like to see a mitigated risk at zero. Okay, but we have got risks in terms of efficiency programs. We've got risks in terms of things like excess inflation, which last time we looked was around £125 million. Mitigating those risks in its entirety has not been possible for, if you like, for day one. We will continue to work on mitigating those risks through the year. NHS England would like us to improve our delivery of our deficit through the year as well. Of course, we'll try to do as much as we can on that one, but our emphasis will have to be on reducing that financial risk in the first instance, never mind reducing our planned deficit of £49 million. The capital programme plan is in the paper. It's relatively straightforward. It's a £230 million plan, includes a 5% tolerance. That's generally been agreed in most part with the provider collaborative. Okay, that part of the plan is relatively straightforward. The last things I would note, Chair, is we have a £49.9 million financial deficit this year. Of course, we'll be working with partners and NHS England on a medium-term recovery plan, so we can get to a more sustainable position. We have to acknowledge the fact that a number of foundation trusts and the ICB have underlying financial challenges. Just in the ICB alone, we've got a £60 million underlying financial challenge on a recurrent basis. So it will be challenging to achieve our financial targets this year, but also a medium-term financial plan that is sustainable. My final points to note, Chair, if that's okay, would be that the plan itself does assume plan for delivery of all other duties. So the Mental Health Investment Standard and Better Care Fund investment levels are as required by NHS England. And my last point was not to forget to ask the board to agree those contract values over £30 million so we can pay our providers. Thank you, Chair.
Okay, thank you very much. You've seen some of the earlier parts of this process, but now that we've got the final outcome for the financial year 2023 forthcoming, are there any comments or questions additionally you would like to raise? David.
Yeah, thank you. Thank you for a very clear report, David. David, our part of this very challenging plan, the ICB's part of this very challenging plan, is deliver some £94.9 million of efficiency savings, of which £48.5 million is non-recurrent. Do you have, what's your approach? I mean, on the one hand, one could wait as a year it progresses to see what fortuitously comes out as underspends, but I wonder whether you're going to use that approach or whether you're going to target planned underspendings in certain areas. It's such a large sum, £48.5 million.
Yeah, absolutely, David. So the first part of the plan, the non-recurrent element, I think we've identified the vast majority of that already. Okay, in terms of unplanned slippages on investments and whatever it might be. So I think we've got that, if you like, in the bag, generally. I think the more challenging area is probably the second part of the plan, which is making recurrent savings.
Okay.
So we are looking to make recurrent savings, as in the paper, in areas like prescribing, in CHC, and non-NHS contracts as well. So we're working with leads in those areas, whether it's medicine optimisation or in nursing or place-based directors, to identify those efficiencies. So that will be more challenging. Some of that we've identified already, and there are other bits where we need to firm up the plans, which is why I talk about risk in that. And the reason it's really important to look for those on a recurrent basis is because of the underlying deficit. I think the £50 million or so of non-recurrent efficiencies is probably masking a little bit the underlying position of the ICB. So it's a bit of a strange position to say we are struggling financially and post a £13 million surplus, but if we aren't ahead of ourselves in terms of, one, getting ahead of ourselves in terms of recurrent efficiencies, we'll struggle going forward. And secondly, those underspends are really important to support the opposite side of the equation, which is the FT side. So to answer your question in a nutshell, David, my attention now is on the recurrent side of the equation.
That's very helpful. Thanks very much, David. Thank you.
David Thompson.
Thank you. Apologies for jumping the gun earlier. Just going back to that sentence, it does say substantial potential risks to delivery. And everyone understands the magnitude of the financial challenges you're facing. But bearing in mind demands on services, how on earth do you decide which areas to potentially cut? What's the process? Do you have impact assessments and so on? And once you've decided where these cuts may be made, how do you convey that information to the general public who are concerned about services anyway? Should you tell them? Do you need to tell them? How do you tell them?
Yeah. That's quite a big question.
It is.
I'll be honest with you, David. So to keep it relatively concise in terms of response, you're absolutely right. It's extremely challenging, the environment we're in at the moment, and that's the same up and down the country. In terms of identifying where we would transform services, because we'll be doing that anyway, there are processes that all organisations will go through and safeguards to make sure that transformation and changes happen in the right areas in the right way. So if I give you an example of that, every organisation would invoke quality impact assessments on any changes they are making. They would also, if there are major changes, they would work through proper governance processes which involve and include the public. Okay, so these things are done in a very open and transparent manner, especially where they're major changes. And some of those changes we would be doing anyway. Graham made the point before, sometimes it's not about doing things, if you like, more efficiently, it's doing things better. So I think we will be required to do a lot of that, I think, over the coming years in terms of a medium-term financial plan. And when we talked about this just recently at Chief Execs, we were very clear, this has to be clinically led. This should not be something that's financially led. This is something about how to make the best use of what we've got. The last thing I'll just mention is we have, as you probably heard earlier, safeguarded certain areas of spend, whether it's the mental health investment standard, prevention, better care fund and the like, areas where we know it totally aligns with the ICP and the ICS strategies. Okay, so hopefully in a nutshell that gives you some confidence in how we would go about that as a collective.
Okay, if there are no other comments, is everybody happy to accept the recommendation in the report? Okay, thank you. Thank you for all the hard work of yourself, your team, and also Sam's leadership on this. Thank you very much. We now move on to the section on governance and assurance, and as I mentioned at the beginning, Claire Riley is unwell and hasn't been able to attend, so Deborah Cornell is going to take us through these items. We're starting with the board assurance framework.
Thank you, Chair. So the purpose of the paper here today is to provide the board with the latest update of the board assurance framework for assurance on its development. The board assurance framework enables the board to see the progress and the risks to the strategic aims and goals of the ICB, and include a link to the lead director and the lead committee for oversight of all of those risks and progress on delivery. The BAF has been reviewed by both the Executive and the Audit Committee since it came to the board previously, and you may say that it is a different format as a result, as we are continuing to develop and evolve the framework as we go through embedding our risk management approach across the ICB. This will continue to evolve as we go forward, because we are looking at examples of best practice around the country as well to help us develop the BAF. And also just to acknowledge that it is still a work in progress. So as a result, there are some areas that we do know that we need to complete and populate and ensure that information is pulling through from the Corporate Risk Register. So really that was all I was going to say in terms of the BAF, but happy to take any questions, and you have a copy of the BAF attached to Appendix 1, but also the supporting risk register at Appendix 2. I'd say happy to take any questions.
Neil.
It's not so much of a question, it's an observation on page 143. It relates to the ambulance handover delay. I guess it's apologies that, as Deb says, that this is still in development. We have numerous mitigating actions against reducing ambulance handover delays. In fact, our performance is, if you compare to other areas, is very good, and I've been contacted by many national leaders to just to explain the work that we're doing. So for some reason it's not pulled through into the BAF. It's just to say that we do have a number of actions in place, including a standard operation procedure of no more than 59 minutes for a handover delay, as well as an aspiration and work to bring that handover delay right down to the 15 minutes. But we'll update that. But I'm not quite sure why it hasn't been pulled through.
It's possibly an earlier draft of the paper. But yeah, I thought that was a bit strange because I'm aware of all the things that have been done on that. So good.
Yeah, so apologies.
Thank you. Okay, if there are no other comments, then we move on to the next item in the list.
Thank you, Chair. So we'll move on to the updated Governance Handbook. So the Governance Handbook, along with the Constitution, which is obviously the next paper on the agenda, it sets out our governance framework, and so there's a number of key documents, such as the scheme of reservation and delegation, and terms of reference for board committees and subcommittees included in that handbook. The documents attached today have been amended to ensure they remain up to date and reflective of the ICB ways of working. So, and the changes are detailed on the front sheet in some details, so hopefully they're quite self-explanatory. So the scheme of reservation and delegation also has some changes as a result of our internal audit on our governance framework that we've just received. There was just some consistencies to make sure wording was appropriate across both the Constitution and the terms of reference, which we've addressed. So happy to take any questions on any of these, but also just to know what there is an amendment needed to the Quality and Safety Committee terms of reference in the membership to include our Executive Director of Improvement and Experience in the membership as well.
Okay. Right, anything to raise there? No, I don't think so. So we're now on to the committees of the board. The Constitution, sorry, yes.
Yes, thank you, Chair. Yes, and the final piece of the puzzle is the Constitution. So again, the Constitution forms part of our governance framework, and we have undertaken a review of the Constitution to ensure it remains up to date and consistent, as I mentioned previously, with the handbook in terms of reference. There are some amendments needed because we did have a change to two of our unitary local authorities in Cumberland and Westmoreland and Furness as from the 1st of April, which have been included in the Constitution, and the board is asked to approve the amendments, which again are detailed on the front sheet of the paper, for them to be submitted through to NHS England for formal approval as per the required process.
Okay, though the original was written just a few months before we came into being, so based on experience, I think it did need to be updated. Are there any questions on that? No? Thank you.
Sorry.
Yeah.
Yeah, I was too slow.
Yeah.
Just a typographical comment, which I mentioned to Deb earlier. On the Constitution, page 16, paragraph 223, it says the board is therefore composed of the following members, and it says 4 non-exec members, whereas at this point it should read 5 non-exec members.
Thank you. Board then. Sam, the Executive Committee.
Thank you, Chair. The The minutes of our meetings from March and April are included within the report. Just 4 key points to highlight. The first is work that we've undertaken looking at the management of complex care packages, which have been aligned to the portfolio of our chief nurse, and we're also in the process of moving the management of those from Tees Esconway Valley into our commissioning support unit. We've covered quite extensively today the operational plan submission for 23-24, and then just a couple of other points. One, I just want to note the voluntary sector infrastructure review that we've initiated and is underway, how we've utilised the primary care workforce under spend against the service development funding is captured within the report, so that has been fully utilised, and also the arrangements we put in place for the commissioning of specialised commissioning, for which the ICB is now responsible for.
John.
Just real quickie on the third sector stuff, Sam. You say we've initiated a review into their structure. I'm just trying to, because I know they came forward with a structure, because I was involved at the time, about how they wanted to do it. What is actually happening, as it were? What's the hopefully outcome of it?
So I'm really happy to share the detailed paper with you, John, but this is basically all of the infrastructure resources across the VCSE sector that the ICB funds and has in place. So they've been, the voluntary community sector has been fully engaged in this, and it's participated within it, but it's looking to make sure that we've got the right type of infrastructure that we need going forward.
That's helpful, because I was involved where they were designing their own internal mechanisms to support it. It's the opposite of that.
Yeah.
Thank you. Thank you.
Okay, thank you. And Eileen Kaner's not here today, so David Perdue is going to make the report on the Quality and Safety Committee.
Thank you, Chair. So the key items above. So we looked at the risks in terms of assurance, particularly related to North Cumbria and then the North and Central Tees. So we've had an update and a new process in terms of patient involvement and experience, and part of that is a patient voice subcommittee, and that was taken through for approval. We've obviously looked at our terms of reference, and they've been redone and re-agreed, and we've had a bit of a deep dive into the committee and how it forms. So our last meeting, we split that into the 3 aspects of quality. So there was deep dives on safety, on clinical effectiveness, and on experience. And part of that was looking at, in terms of clinical effectiveness, the ICB's process in terms of NICE recommendations and how we systematically address NICE guidance. So just happy to take any questions.
Okay. There's a lot of work covered in these committees, so if you do want to follow up on anything or have a longer look at it, do flag up outside the meeting, and we can have those discussions, or bring anything back to the board that you think needs to have a board level discussion. Okay, thank you. On to the Finance, Performance and Investment Committee then, John.
Thank you. Again, a lot of this has been spoken about by the presentations from David and Jacqueline, but obviously for us, in terms of what we're doing, was the financial position for the ICB and the ICS for finishing the end of year. The performance position and concerns, and there, obviously, again, Jacqueline has explained some of those, but again, improvements that we've had, as well as, and sadly, the deterioration in the A&E performance, and just really looking forward to what we received around 23-24 financial and operational plans. And again, the interaction between, I think, the committee and the delegated responsibilities to try and support that being achieved, rather than just coming through the committee all the time, actually making sure that Sam and David had some delegated responsibility to try and actually deal with that in the timescale that was given. So I don't really want to add much more than that, Liam, to be fair.
Any questions or points anyone wants to raise? Thank you. And now, Deb, we have some questions from the public that have been submitted.
We have, yes, and say in response to a question from Roger Nettleship, who's a resident in South Tyneside. So looking through the documents and constitution of the ICB, I'm finding it hard to ascertain who actually now has responsibility for commissioning the health services in each area and overall, and how that is agreed. Previously, it was the CCGs in each area. So in response to the question, see, we've got the ICB is the statutory decision-making body for the commissioning of health services and the effective stewardship of NHS spending for all the people who live in the North East and North Cumbria. The Constitution sets this out on page 7 and it's under section 1.1. The Constitution and Governance Handbook also sets out how we delegate decision-making authority, functions and resources to all of our places to ensure we meet the diverse needs of our citizens and communities. We do this by working with our place-based partnerships, which include representatives from local authorities, health and care providers, the voluntary, community and social enterprise section, and also with Healthwatch.
Thank you. We had other call for other business at the beginning, and there was nothing other than that listed on the agenda. So we draw a meeting to a close. At one point we had Naib Evan gazing down on us. He left at the time of the finance item, but he's gave us a bit of inspiration anyway in the second part of the meeting. So thank you very much, everybody, and look forward to seeing you next time.